இது பேச
தானே?
ஆமா சார்.
அதுல ஓபன் பண்ணணும்.
ஆமா சார், இது ஓபன் பண்ணாதான் சார் அங்க.
Which is the file Intel is asking? Is this the file or this is the file?
டபுள் ஓபன் பண்ணு.
Rohini, if not, you send it to me.
Yes, auntie. It's opening.
Okay.
Slide கிட்டது.
This is not the slide. சரி, இது க்ளோஸ் பண்ணுங்க.
And unless you put, I won't know to it.
இந்த ஸ்லைட் கிடையாது சார்.
இல்ல,
ஓபன் பண்ணி மொத்தம்.
You remove this. இது remove பண்ணு. Just minimize பண்ணுங்கப்பா.
பா. இதுல இருந்து ஃபாக்ஸினா ஃபாக்ஸி
ஃபாக்ஸி ஜான்.
அதான். இந்தமா.
சரி, இந்த ஸ்லைட்ல போட்டுருங்க. ஸ்லைட் மோட்ல போடு. இங்க பிரஸ் பண்ணுங்க. Now மீட்டிங் போங்க. இல்ல, மீட்டிங் போங்க.
Rohini, please mute.
Good evening, sir.
Sir. Rohini got it?
Madam, start பண்ணிடலாங்களா மேடம்? கார்த்திக் ப்ரொஃபசர், குட் ஈவினிங் சார்.
எஸ் சார், குட் ஈவினிங் சார்.
சார் ஸ்டார்ட் பண்ணிடலாமாங்க சார்?
சார் ஓகே சார், ஐ அம் ஓகே சார்.
Slide show.
Now open.
Good evening, Dr. Karthik. Good evening, sir. Karthik Guru, sir. Good evening.
Good evening, Anand sir. Good evening.
Right, Bhavdani madam, sorry, slide open ஆயிடுச்சு.
Next slide.
You can start.
இதம்மா?
Yeah, start.
Can I start now?
Sir, you just change the slide, sir.
Sir, just inaugurate the session, sir. Then we can start.
Okay.
Change the slide, sir. Sir, change the slide, sir.
மணிபதி சைடுல.
Yes, sir. Sir, getting change.
பார்க்க சொல்றேன் சார்.
தெரியாது.
Good evening, sir.
Good evening,
sir.
Good evening.
Sir, light கொஞ்சம் face கொஞ்சம் light focus ஆகணும் சார். Light சார், face சரியா தெரியல சார்.
அட போய் நான் நல்லா இருக்கேன்.
சரிங்க சார்.
Madam, we'll start the program, madam.
Yes, sir, we can start.
Yes. Meeting call to order. Anand sir, we can start there.
Good evening, sir. Good evening, all of you. So, I first invite Dr. Vivek, our CME state officer, to Dr. Vivek. Dr. Vivek. Vivek, line la இருக்கீங்களா?
Sir, line la இருக்கேன்.
Physics start பண்ணலாம். IMA prayer start பண்ணலாம் Vivek.
May everybody be free from sorrow. May we be the healing cure beyond every creed and lure.
Hello.
Sir, கேட்டுச்சுங்களா சார்?
விவேக், நீங்க பேசுறது கேட்கல. இப்பதான் நீங்க பேசுறது தெளிவா கேக்குது. சொல்றீங்களா?
சார், இப்ப இன்னொரு வாட்டி சொல்லட்டுமா சார்?
சொல்லிருங்க விவேக். எல்லாத்துக்கும் கேக்குற மாதிரி சொல்லிருங்க.
I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure.
Thank you, Dr. Vivek. Now I call upon Dr. S. Gopalakrishnan sir, IMA CGP representatives to say the physician prayer. Dr. Gopalakrishnan sir, are you online? Gopalakrishnan sir. Okay, Nane Solir, I'll say myself. Physician prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart, give singleness of purpose, strength to life, at least a part of the burden of my suffering fellow men, and a true realization of rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I rely on thee. Thank you. Now I invite our State Secretary, Dr. Karthik Prabhu sir. Sorry, our State CGP Chairman, Director of Studies, Dr. Senthil Kumar, to give the welcome address. Dr. Senthil. Dr. Senthil.
It gives immense pleasure to welcome you all. I welcome our Honorary State Secretary, Dr. S. Karthik Prabhu sir, our President, Dr. K. M. Abdulasan sir, and our past President, Dr. Sendamal Pari sir, President-elect Sridhar sir, and our CGP team, Dr. Vivek, Dr. S. Gopalakrishnan sir, and Dr. Suresh Kumar sir, and the star speakers of the day, Dr. Batmashri Professor Dr. V. Seshaya sir, Dr. Balamurugan sir, Dr. Panniserlam sir, and our CGP Diabetology Course Coordinator and Speaker for the day, Dr. Bhavdani Madam. We welcome you all to the day. We had good registration, we had good support and participation across the state and even from other states. So we have as of now 800.
Senthil. Senthil, you are not audible, Senthil. No. Dr. Senthil. Hello. Hello, am I audible?
So, sir, it got stuck.
Now is it okay, madam? Now is it audible or now it is
Okay, you are clearly audible. Senthil Nala is not able to connect, I think. You can proceed, I think.
Okay, madam. Okay, then I Dr. Senthil, thank you for your kind welcome address. Now I call upon our since our state president sir is held up with some personal work, I now call upon Dr. Karthik Prabhu sir, our IMA state secretary, to give his address. Dr. Karthik Prabhu sir.
Sir, unmute.
Sir, am I audible, sir?
Yes.
Yeah, you are clearly audible, Dr. Karthik sir.
Yeah, thank you, sir. Most respected President Abulasan sir is not available today because his sister's husband has passed away. He's in the condolence function, so he conveyed his excuses through me. That is an apology to CGP. Second thing, sir, and today it's a wonderful meeting organized by the chairman, Dr. Senthil, Secretary, Dr. Anand Chokalingam sir, and what a function, sir. I really feel very proud because you've done a phenomenal job the panel regarding the prevention of diabetes, what you made, you brought in giants like Dr. Sheshaya sir, who's been even, I think, if I'm right, has been the person treating from MGR times. Dr. Balamurugan, a very, very renowned diabetologist here in Kovai Diabetes Center. Dr. Balamurugan, Dr. Paneer Selvam sir is a very update man, and Bavadarni madam, a wonderful human being who's been a part of the CGP for such long years, a nice soul. இவங்க எல்லாரையும் வச்சு இந்த அளவுக்கு அருமையா இந்த சிச்சுவேஷன்ல நீங்க மோஸ்ட் ரிக்வயர்ட் பார்ட்டை நீங்க பண்ணிருக்கீங்க. மை பெஸ்ட் விஷஸ் அண்ட் கங்க்ராச்சுலேஷன்ஸ் டு யூ, அண்ட் ஸ்டேட் ஆஃபீஸ் will always do all the supports to you, and I congratulate all the speakers and from the bottom of my heart, thank you sir, all of you, and best wishes to team CGP. Best wishes sir. We'll go into the program. Thank you.
Yes, sir. Thank you, Dr. Karthik Prabhu sir, for your very kind words. And as a state secretary of this, faculty secretary of this CGP, I would like to welcome all our speakers who are stars of today, and our president sir, Dr. Abdul Hasan sir, our secretary sir, Dr. Karthik sir, our immediate past president, Dr. Pari sir, and our incoming president, Dr. Sridhar sir. As a secretary of this CGP faculty secretary, I would like to place it on records like this is the inaugural CME for this year's fellowship course, for which already we have 21 registrations, and we expect more in the coming 1 week, which we have planned to extend. And moreover, this year we have discussed with the course coordinators and with the state office bearers, and we have thought of taking it to the next level of getting an affiliation to any of the universities abroad or in India at least. So as a part of this thing, I don't want to waste my time. Like prominent speakers are waiting to be giving their talk. I would like to end it here, and I would like to call our immediate past president, Dr. Pari sir, to give his felicitations. Pari sir. Dr. Pari.
Respected State Secretary, Dr. Karthik Prabhu, President-elect Dr. Sridhar, newly elected office bearers of CGP, and speakers of the day, my dear friends. First of all, I would like to congratulate the new team. Dr. Sendil Kumar, Chairman, is my good friend, and Dr. Anand Chokalingam is also my good friend for a long time, and Joint Secretary Dr. Suresh Kumar, CGP representative Dr. Gopalakrishnan, and Vivek, all this team arranged a very good inaugural CME of diabetology course today with very good speakers, particularly Professor Padmasri, Dr. Sheshaya. He is a well-known, renowned diabetologist of our state, and Dr. Balamurugan, Dr. Paneer Selvam, and Dr. Odarani Madam. All are very good speakers and teachers of diabetology. I hope the course will pave good way to the doctors in the field of diabetology. I hope this CME will be more useful to the general practitioners of our state and also other states. Thank you for the opportunity. Thank you.
Thank you, sir. Very kind of you for your kind words, sir. Now I call upon our state president-elect, Dr. Sridhar sir, to give his felicitations. Dr. Sridhar sir.
Yes, Dr. Anand, thank you for the golden opportunity.
Yes,
my greetings to everyone there, right from our immediate past president, Dr. Sindhamal Pari sir, Honorary State Secretary, Dr. Karthik Prabhu, the CGP leaders, Dr. Sendil Kumar, Dr. Anand Chokalingam, Dr. Vivek, and the excellent doyens of speakers in diabetology, Dr. Sheshaya sir, Dr. Balamurugan, Dr. Panneerselvam, and my dear Madam Bavadarini. And it is a great privilege. The days when I was faculty secretary CGP, and for the first time we took the CGP to the small towns like Arandangi and Sriviliputtur, used to conduct meetings there. And our leaders and teachers used to speak over web camera through online. That was the time when just the modems had come, through which we can connect internet and start speaking. And after that, we saw a lot of interest across Tamil Nadu in our diabetic courses, FCDs. 200 to 300 students used to participate. And CGP used to be the biggest breadwinner for Indian Medical Association. And the convocation used to be a grand affair. And I think slowly we are getting back to those golden days. Today, I see the attendance around 616 of just now. And he says, Dr. Anand says the registration has crossed 800. So I think our golden days are back. We are on to the target of training our people, empowering our doctors with the latest in all the fields, more so in diabetology, which is touching every field in medicine, whatever be the specialty, ophthalmology, ENT, skin, whatever you may call it, every field diabetes has a touch in it, and it has become a must that everyone should know the basics of it. So this is an excellent opportunity for those who cannot attend university courses, who are living in rural areas, practicing there. And I am very sure IMA CGP, with its excellent reach through Zoom, will do so in the coming years in a more excellent manner. I wish this function and program a grand success, and I just see it as a beginning of a grand show for the next 2 years. Congratulations to you, team IMA CGP. Thank you for the opportunity.
Thank you, sir. Very kind of you, sir, for your encouraging words. We'll try to follow your advice, sir. Thank you, sir. So
Anand, sir,
now it's time for us
sir,
to
Anand,
go
Anand, sir, now,
sir.
Anand, sir, now we are going to inaugurate the diabetology course, and it is none other than our honorary state secretary, Dr. Karthik Prabhu, sir. Sir, I request you to inaugurate the session as well as the course, and also say a few words about this, sir. Thank you, sir. Karthik Prabhu, sir.
Sadil.
Karthik
Prabhu, sir.
Karthik Prabhu, sir.
He has already given us a view, and I think is he online?
Yeah, see.
Shall we start with the first speaker? Shall I? Sandil?
I think he is trying to reach out to the honorary state secretary. You can give him
Yes,
a
sir.
minute.
Okay, sir.
Anand.
Sir, I'll give us. We'll start with the CME, sir. Sir is waiting for a long time, sir. So I would like to take this opportunity to introduce the first speaker. Yeah.
Padma Shri Professor Dr. Seshia.
Yes, sir. I would like to take the honor in introducing our first speaker for the day, Professor Padma Shri Dr. V. Seshaya, sir, who's called as the Pitamagar of diabetology in India, maybe not in Tamil Nadu. So he has so many honorary distinctions.
I think Karthik has come back. Anand, Karthik has come back.
Sir, I've come back, sir. Sir,
yes, Karthik, can
yes,
you officially inaugurate the...
Yes, sir. Sir, officially we'll inaugurate, sir. I'm happy to inaugurate this course officially. And only 3 points, sir, I just want to add. This course is a wonderful course started by the doyens of the profession. Let it be Sheshya, sir, Balamurugan, sir, everybody. And Bavdarani, madam, எல்லாருமே இவ்வளவு வருஷமா diabetes practice இருக்கீங்க. And you are going to train us, and the motive of the students here who are going to join in and who are going to learn is not to put ourselves as a consultant, but to be empowered to treat the difficult cases, so that as MBBS doctors, everybody can treat diabetes. Adukku whatever knowledge is required, our CGP is ready to provide. And I request all of you to take it and go within the legal stipulation so that we have a safe and peaceful practice. With this, I am happy to inaugurate this course and I congratulate all the people and the team for this. Thank you, sir. Thank you so much.
Thank you, Dr. Karthik Prabhu, sir, for your official inauguration address. Thank you very much, sir. Now I would like to introduce our first speaker, Padma Shri Professor Dr. V. Sheshaya, sir, who is honorary distinguished professor of the Tamil Nadu Dr. MGR Medical University for life, and he is a patron for Diabetes in Pregnancy Study Group of India. He established the first department of diabetology in India at Madras Medical College in 1978. And Diabetes in Pregnancy Division in the Institute of Obstetrics and Gynecology, Government Maternity Hospital, Egmore in 1980. He was the recipient of Dr. B.C. Roy National Award in 1988 for the development of diabetology as a specialty in the country. Lifetime Achievement Award by the International Diabetes Federation in 2017. He is the first Indian to receive it. And he was awarded the Padma Shri in Medicine by the President of India. So these are few of his achievements. Sir, we feel honored to listen to your lecture, sir. So now the stage is yours, sir. Sir, please, sir.
Dr. Anand, sir's birthday, March 10th is
sir's birthday. Yes, ma'am.
Yeah, it's a GDM Awareness Day, celebrated as GDM Awareness Day in India and also in the other countries.
Okay, so that's a very great honor, sir. We are very proud to listen that it has been developed gestational diabetes wellness day in all over countries, all over the world. So very good information, madam. Thank you for intervening and telling me this information. Thank you, madam. Sir,
requesting everybody to mute other than the speaker.
Yes, madam. I request all the participants to mute so that sir can give his address. Thank you.
Dear members of the Tamil Nadu IMA, thank you all for inviting me for this meeting here. And you are all speaking so well, very well. I can only speak topics, but not like you people. Very good, excellent. Anyway, thank you very much. Let me speak on this topic, which is a very bother. I don't know why she called me. She called me. I said, okay, I will come. Because this topic is very latest topic in the diabetology, and also mostly it is in the field of gynecologists. Of course, physicians, diabetologists, and endocrinologists also should know what I am going to speak now. So with this, I thank you all very much for this opportunity. I wish to share with you my experience with this particular topic, because this is the first time I'm addressing the Tamil Nadu IMA. So path-breaking concept, full screen. Can you get the full screen? I'm not able to get full screen.
Sir, no, it is in full screen only, sir. You can sir. It is in full screen, sir.
Yeah, half of my slide is covered.
Yes, sir, press, sir. Again, you press,
Yeah, we are able to get the full screen.
You are?
Yes, sir.
You are able to see full?
Yes, sir,
yes,
full
sir,
screen.
Sir. We are all able to see, sir.
So I am going to speak now. Latest concept on this path-breaking concept has become reality for primordial prevention of diabetes, and I divided into few subdivisions also: epidemiology, endocrinology, embryology, and also drugs. Estimation projection of the number of people diabetes with the different editions, millions will be like this. Here, 219, it was 463 million. In 2021, it was 537. It is going to be 245, 70-83 million population will become diabetic. So that is why it's so increasing. And also we know pre-diabetes approximately 318 million, which is likely to increase to about 480 million by 2040. So this is why our friend Andrew Burton told that diabetes is not epidemic now, it is becoming pandemic. So this is the most important message, epidemiology. Now, many things confusing people. Detection of diabetes does not mean prevention of diabetes. You may be screening and say, okay, you got diabetes, but it doesn't mean you're preventing diabetes. This is particularly important message here. Detection is different from prevention. Now, another thing also I want to share with you the concept. What we need is primordial diabetes, that is, disease should not develop. Because this is the concept I'm starting now. Primordial prevention of diabetes, that is, disease should not develop. Let us see what happens here. Is it possible now to achieve diabetes-free generation? Whom to focus? That is very important now. Whom to focus? Now, this is what happened. We know female gender is the key for diabetes prevention. Lisa King told a long time ago, and that how this expression is given here. The body's susceptibility to lifestyle diseases was programmed intrauterine. That is why I said focus on the female gender. As the Dwight Barker made the statement long time ago. Now, having discussed this, the intrauterine environment is very important for this primordial diabetes. Here, gestational program is a process wherein stimuli are cells that occur critically or sensitive period of fetal development, permanently change structure, physiology, and metabolism, predisposing individuals to disease in the adult life. So this in a nutshell, everything happens to be in the programming in the mother's womb, that is called gestational programming. Now, that is why we call fetal origin of adult diseases. So everything starts from the mother's womb. Now, what happens here? Developmental origin. Since I told the statement here, then the ovum is well supplied with the mitochondria, but those contains a few, even those few do not persist in the offspring. And then, most importantly, at fertilization, it's only the nucleus of the spermatozoa enters the ovum, only few. And thus all cytoplasm, mitochondria, and mitochondrial DNA exclusively maternally inherited. So there's obviously most important person to be taken care of the mother. Would be mother. So if you want another angle I'm going to discuss here, diabetes mellitus, is it due to, as I just mentioned a few minutes ago, it's the entire environment, or it is going to be the innate destiny. See, many people think my father diabetic, so I am diabetic. That's the genetics. Okay, let me see which is more important. Is the internal environment is important, or genetics is important? Animal experimental model that shows here, this is the explanation I'm giving. Blister rat, the low genetic risk of diabetes. When exposed to hyperglycemic media of goat rat, significantly increase the risk of diabetes in adult life. So the experiment has clearly showed that exposure to mother's womb, diabetes is more important here. Animal experiment. Now, what will happen in human being here? Maternal hyperglycemia and progeny. What here? The offsprings of Pima Indians who were when their mother had gestational diabetes or GDM, have greater risk of developing diabetes compared to then earlier siblings born before the mother developed GDM. So this shows again intrauterine environment is very important here. So animal experiment and the human being both have established the fact that uterus is most important here. So intrauterine milieu is most important than the inherited destiny. What is that? Hyperglycemic pregnancy here. Hyperglycemic pregnancy is diabetes, any degree glucose tolerance with first taken during pregnancy. So GDM is the mother of non-communicable disease. This is what I find this statement here. Everything is the mother, GDM is the mother of non-communicable diseases. So what I have to do here is how to prevent the development of non-NCDs. diagnose GDM, this message is very important here. Diagnose GDM is second or third, that's what we do. GDM is when people do only screen at present, second, third trimester. It's not successful in preventing NC non-chronic disease. So what we should do, once GDM occurs, it will definitely, NCD will occur in the mother and the progeny. So here, health at which antenatal week has to be taken into consideration for diagnosis, each antenatal week. And then also here, what screening test and diagnosis is to be recommended. This is now question I'm putting again in front of you. Now I'm going to answer. This is what screening test and diagnosis to be recommended. Now we look at this. This is a beautiful slide of IDF. International Federation shows every country has got the guidelines for the diagnosis GDM. If you go to America, ADA will say one guideline, and American College of Hospital another guideline. ADIMS another guidelines. So you see every DIPSI one guideline, ESD another guideline. So you see the how can it be? How can you think about GDM? Different country will have different diagnosis criteria. So there is something wrong with that. There's nothing, nobody has got uniformity. Suppose somebody comes from America, they will told GDM is positive. When it comes to Chennai, we will say it is negative because our guidelines is different compared to American guidelines. So that is a big problem of this here of diagnosed GDM. Please remember, I just stress here, this table shows diagnosis of GDM, number of countries have got that. So coming up, different countries, different guidelines for diagnosis of GDM. Even the same country has two guidelines which led to confusion among the healthcare professionals. Even in India, some people follow DIPSI criteria, somebody will follow IDFC criteria. So this is like America, ADA. So absolutely not so much of confusion going on in the world. So please forget about this. Don't follow any of these things. This is only for GDM. What you want to do, how to prevent GDM. This is not diagnosing GDM. What I am bothered is prevention of GDM. Because of that, we can prevent diabetes. So with that concept, I'm going here. Therefore, the physiologic glycemic level in normal pregnancy has to be recognized and implemented. So anything above physiology is abnormal. So like your Ramayana, Lakshman Rekha, crossing the Rekha, she got a problem. Same thing, why should you cross physiological glycemic level? That is the reason, this is a very important message. The physiological glycemic level, normal processing has to be recognized and implemented. Anything crosses physiological level is abnormal. Now you see here in this study, pattern glycemia and normal pregnancy, the wonderful data here. You'll see here 2-hour blood sugar post, it is not post glucose, it is postprandial blood glucose is 2 or more, less than 100 normal. Anything above 210, 2-hour postprandial is abnormal. So this is cutoff point for the diagnosis of abnormality during pregnancy is 110. Any value above normal is abnormal. That is means any value during in the pregnancy crosses 110, it is abnormal. It should be less than 110. That is why I gave a previous slide physiological cutoff point. If you are convinced about this, next slide will be easy to follow here. Now, this is what I told you. Now we have to go to physiology. Now go to embryology of beta cell development. Why it is important here? Each islet cell functions as an endocrine organ. Each islet cell, if you take in the fetus development, each islet cell. What is the importance here? The human pancreas begins to develop 4 weeks after conception. And the first insulin deposit can be found between weeks 7 and 8. Pancreatic cell differentiates at 10th and 11th week of this. This is very important message. Pancreatic islet cell in the fetus differentiates at 10th and 11th week gestation, and then what happens here? It recognizes and responds to maternal glycemia at 11th week of gestation. Now, the important message I want to share with you. I told you normal blood sugar level physiology is 110. keep it on side. Here, when the fetus is developing in the womb, when it crosses 10th week or 11th week, it recognizes the mother's blood sugar. That means it looks, suppose that fetus can look at the mother at what is the blood sugar level of my mother. It is going to be more than 110, is a problem. That is the fundamental message I want to for you to tell fundamental message here. Now I'm going to little bit here physiology here, glycemic level and gestation weeks of prediction of GDM. So most of you will be following different 24th week, 30th like that. Here is entirely different concept here. Gestation glycemic level at gestational week for prediction of GDM. Here is very interesting point here. First time National Institute of Health study in 2018 suggested A1C 5.3, that is pure personal blood sugar, which I told you, 110 milligram at 10th week predict GDM. So again, this is a very important message. At 10th, as a previous slide I told you, insulin start in the fetus when mother blood sugar goes up. At what level? 2 people more than 110 milligrams, the mother at 10th week predicts GDM. Why? How? Hence, blood glucose has to be brought to less than 10 milligrams so that fetal beta cells start secreting insulin around 10 to 11th week. So, 110 week, the mother blood sugar 10th week, less than that, it's okay. More than 10 milligrams, she will develop GDM. That's why we have to take care and bring blood sugar level less than 10 at the 10th week so that mother will not become GDM. So, but so far, now I'm going to another side. But so far, no explanation has been for the prediction as well as for the prevention of GDM. As I told you, more than 10 is a problem. So it should less than 10 to avoid GDM. But what is the explanation given? So far, no. Now I want to give it. So conceptual, this I conceptually putting both endocrinology and embryology here. Maternal to our postprandial blood sugar should not cross 110 milligrams. First message. At 10th week, as fetal beta cells start secreting insulin around the 11th week of pregnancy. So this 2 points is very important. 10th week mother, 11th week fetus. So 10th week blood sugar should not be 110. Crosses next week itself, the chance of fetus secreting more of insulin, and is going to be what could happen because of that. Blood sugar, here what could happen on the insulin secretion of the fetus. I'll discuss subsequently. So this is called fetal handling of maternal glucose. Very brutal embryological study here, and a physiological study, fetal handling of maternal glucose. I think many people may not be aware of this. Fetus handling the mother's glucose. Because of that, what could happen here? I'll give an example here. If at the 10th week, as an example, 10th week, suppose her blood sugar is 126 milligram. So a woman comes to antenatal clinic, obstetrician check the blood sugar to 126. She will not know what to do with the 126. So when she comes here again, 12th week, it comes on 112. She is very happy. The blood sugar is 126 has come down to 112. PPBS comes down through any intervention. So she thinks, tells the lady, your blood sugar is normal, it has come down. And then how this came down is important. This is what I am going to share here. Again, this point is very, very important. The 10th week and 12th week, I told you, very important weeks. 10th week, mother blood sugar is high. 11th week, got level. This brings fetal insulin, brings down the maternal glucose, which is not desirable. So what happens because of the physiological action, when 10th blood sugar reach more than 110, if nothing has been done, 11th week secretion of insulin starts in the fetus and it brings down the maternal blood sugar level. So maternal blood glucose does not go up due to fetal insulin handling maternal glucose. This is a very important message from the fetal handling of maternal glucose. Now, the guidelines to screen glucose tolerance at appropriate, this now it's more of clinical side here. Guidelines to screen glucose tolerance at appropriate decimal weeks. What time we should do that? This is also this is more of applicable to clinical side. So here, as I told previous slide, 10th week is very important. 10th week, if PPB is more than 110 milligrams, unfortunately, imagine a blood sugar cross 110 10th week. What would happen here? 11th week, fetal, as I told in the previous slide, fetal beta cell insulin secretion starts and continues at 11th week. Once it starts, it will never come down, so it goes on. So what could happen because of this, as a pregnancy continues, glycemic control is optimized very early in pregnancy to prevent the establishment of the fetal hyperinsulinemia. That is very important message here. Goes on. Once it starts, 11th week, nobody can start. Continues. So that presently what is happening is screening for GDM is done in the 24th and every book says 24th week, 24th week. So that should be changed. Now we should go for presently the test for glucose tolerance in the early weeks of pregnancy is the process. EGI, it's going to be, I won't tell you what is EGI. Early gestation glucose tolerance should be introduced shortly at present. At present, still people follow 24th week. Now we must come to this week of EGI. So the phenomenon of anticipation, this is another very important clinical implication here, phenomenon of anticipation. See, islet as an ideal is a test for glucose tolerance at 8th week. This is first time introducing word 8th week. And 2 months, because 10th week is going to be a crucial period. It should not be 110. So we have to anticipate, so like going for examination. Exam in the month of March or April. Now it's time to prepare. We know something would happen at the April. So now we prepare for examination that nothing could happen. We can pass the examination. Similarly, here also, ideal is test for the glucose. No book says, this is only I'm telling now. So it has to be done at 8th week itself, 2 months. If woman comes, you must ask her to come on 8th week. So prediction of GDM, as I told you earlier, is 2 personal blood sugar more than 10 milligram at 10th week. That is the prediction. Then ends at the 8th week itself, this information we have already got. At the 8th week itself, PPB has to be estimated and milligram must follow by Martin CPG at 10th week. Our 8th week, then 10th week. Suppose in 10th week, in case PPB is more than 100 milligrams and less than 119 at the 8th week, a grace period of 2 weeks available, as I told you, 8th week to 10th week, 2 months is available to attain post-prandial blood glucose less than 10 milligrams at the 10th week with MMT or metformin. So the whole thing is anticipation. It's not book, no tells us. Now 10th week is a problem, so we have to prepare ourselves. If I prepare ourselves, enemy is coming, I prepare myself with weapons. I prepare myself 8th week itself, but less than 110, we leave it like more than 10, immediately must be the blood sugar, the drugs for the control, bring it down. So with that, now next point will be, so I'll make another easy way. So weeks 8th week, imagine more than 110 milligram. In that time, you must give intervention with the medical therapy and metformin. 10th week, it comes down because already started the treatment less than 10 milligram. So what will happen? The grace period of 2 weeks available to bring it down. So 11th week is very crucial week. It is still 110. So nothing will happen to the fetus, neither for the mother becoming GDM. So after it continues, no increase in the fetal beta cell, no increase in beta cell secretion occurs in the mother. So and follow up every week because we once started at 8th week itself, we continue to give the drugs here, metformin and the MNT. Suppose a 10th week patient comes to you And if I 110 milligram and above, you don't have any time because the problem anticipation as I showed in the previous slide, not possible here, more than 10 milligrams. Not enough time is available to achieve less than 10 milligrams. So it's not a problem now. There's nothing can be done here. Fetal secretion starts increasing here. So all these things shows the important is you have to take action at the anticipated action of 8th week. So that 10th week, I blood sugar one down less than 10. After that, there's no problem for the fetus or no problem for the mother. Now what happens here? Having decided that, then why you are telling 8th week? Because here you will see here on eighth week, that is called fetal embryonic stage. After the 8th week, it's called fetal stage. So in this time, in the 8th week, everything is over. So you can safely give any tablet, including metformin. Of course, for PCOD, give even before pregnancy. So metformin seems to be very, very, very safe drug. So even then, even those who are doubters who got worried about them, this study shows 8th week embryonic stage is over. We can boldly give metformin when blood sugar is crossed 110. So if two or PPG more than 10 milligram, metformin and medical therapy, 250 milligram BD has to be started and continued. That's very important. Continued. Target glycemic to obtain PPBS 99 plus or minus. That is means between 90 to 110 should be the range you must have it. So here a number of studies have shown it is safe. Metformin is safe as embryonic stage is even by 8th week. Here, metformin is safe for use throughout pregnancy. Glucophage was approved as the first anti-diabetic medication to be used safely from conception to birth. That is the important message. I am giving the evidence here. The number of publications are there. Now, Government of Madras Medical College Ethics Committee has also approved metformin can be given to the pregnancy. That is how we introduced in the Kilpatrick Medical College, Kasturba Medical Hospital. So one message here, you miss the bus. Initiation of metformin after 12th week will not be effective in producing GDM. So all your time is wasted. If you unfortunately if you screen there only at 10th week and you find the blood sugar is more than 110 milligram, if you give metformin, nothing will happen. She will continue to develop GDM. They can't prevent it. So early week is better. So this is what we did about in the year 2012. We published the article in 2022, prediction and prevention of diabetes mellitus, and it's sequelated by administering metformin early weeks of pregnancy. That was a concept published in the Cure. That is a technical report. It was published. So now I'm going to go to and next stage here. Concept has become reality. We believed that now evidence will be the reality. Outcome of preliminary study will be here, and these are the people who are involved in the study from the Chennai as well as from the Bazar here, project sponsored by USV. Here what will happen, data analysis, group A, now I'll share with you what happened here. This is group A, 8th week. 8th week, 2 personal blood sugar, less than 110, no intervention, not necessary. Total case of screening was 82. Now it's ongoing study. When group B at 8th week, 2 people more than 110 milligrams, and intervention metformin and lifestyle modification, total number of cases will be 70. So less than 110, we don't give any medicine. More than 110 milligrams, 8th week, start straight away metformin and as well as MNT. So here data will be here. See, group A, 82. In the first trimester, GDM, second trimester, 64, again no GDM. Third trimester, GDM, one lady developed GDM. That is called multipara. Another group B, which is started 8th week, more than 110, started with the metformin. There's no problem. first trimester, second trimester, third trimester, no problem. Only third trimester, one lady developed GD. That is because she stopped the drug because she wants to become absolutely normal. So that is what happened now. So the study shows continuing the medicine throughout pregnancy has had an excellent outcome. So group A, one enrollment developed again GDM in third trimester. Out of 41 cases, completed third trimester OGCT, and group B, anti-enrollment developed GDM in the third trimester. Out of 33 cases, discontinued metformin, completed third trimester OGCT. So that is what happened. This study shows what the concept was given has become reality. This is again, it's a little more different way of doing it. Now, 8th week and 10th week, the green line. The brush over here between 110 and 119. More than 119, we don't take this for the study. The study was taken, and the reason is that I'll tell you what happened here. When this level, immediately we found all the studies, average blood sugar was 112.5 milligram. That time we started the metformin here, 8th week. Once it started here, then we continued. It's called early gestational week in 10th week. 8th to 10th week, EGI. Then once it started, we continued. There is very, very important message. Don't stop the drug, which we initially, once it started, it's very, very safe drug. I told you the previous slide, it should be continued so that outcome will be very, very safe. If it is going to be more than 120 milligram, we can't include them. There were going to another problem would be gestational glucose intolerance. Here they say early gestational glucose intolerance, EGI. Here gestational glucose intolerance, this is glucose based. And same thing again 140, the classical GDM. So this is entirely different red line is you cannot, you're not, this occurs, they will get develop all GDM. Whereas here in the EGI, early gestational glucose tolerance, 8th week you start treatment with metformin, and 10th week blood sugar comes to less than 110. After that, you maintain the blood sugar level same continuous less than 110, but continuing with the metformin and lifestyle modifications. So here, glucose related, the red one, and this one is the postprandial. Please do not confuse. The 110 is not at all due to glucose, it is only postprandial. Whereas GDM diagnosis is made by glucose. It's a very, very important message I will not share with you. So categorization glycemic dependency, GDM glucose based, 2 ppg more than 140 milligrams. And GGI, this is glucose intolerance and glucose based 2 or more than 110. Here, EGI, early gestational glucose intolerance, is postprandial blood sugar based. So 2 or pp less than 100 milligrams. That is very, we can't confuse between the GDM, GGI, and EGI. The different concept. So the normal glycemic tolerance will be 99 plus or minus 10, that is less than 110. So summing up, just the final message, this kind of prediction of GDM, 2 or postprandial blood sugar, more than 110 milligram on the 10th week. But action has to be taken little early 8th week. So this is prediction of GDM. So next, prevention. How to prevent has to be taken at the 8th week itself, so that maternal pregnancy remains less than 110 milligram throughout. What a simple message for you. Do 8th week, give metformin more than 10 milligram, and then continue. Prediction of GDM will start there, it will go away. So prediction, 2 or ppg more than 10 milligram. Prevention action has to be taken 8th week, and throughout the medicine sugar should be less than 10 milligram. So metformin and medical therapy will be continued till confinement is essential after delivery. So finally, aim is to maintain throughout pregnancy and from conception to confinement. 2 ppg, as I told you, 99 plus the 110, that is value. Monitoring 2 ppg, you can do 8th, 10th week, 12th week, finished, nothing can happen. 16th of May, this is a week, you can do it or not, it's okay. This is very important, the green. Other things are we need not worry about that because not necessary as metformin won't be useful at 12th week and 16th week and all you can do the test to check GDM if needed because of the criteria. So most important test if you want me to tell you 8th and 10th week. So anti-women likely to visit clinic regularly. If you go and ask her to come every week, they may not come. That's why you must stop with that. So finally,
where is the screen?
All of you, please mute your microphones other than the speaker.
The womb is more important than the womb. It all starts uterus. Hence, for diabetes-free generation, focus on the fetus for the future. Blood test at appropriate time, and use acute check. Don't use digital glucometer. It's not my company, but it is proved. This is the best meter for the particularly for pregnancy and hence male, female gender. The key to diabetes prevention start with healthy pregnancy. So all these things will occur here. So my dear friends here, let us all pledge for primordial prevention of diabetes. I am very much aware this topic is entirely foreign from the people who are listening to this talk because many may not be teaching the current women. So because the Bhavadar told, I accepted to speak on this topic because the group is to be different. So anyway, thank you very much for this opportunity. Thank you.
So a very elaborative and a very essential talks of primordial prevention. It was very nice, sir. It was very informative. So thank you very much, sir, for sparing us your valuable time. So I think we shall move on to the next topic, ma'am. Next topic will be on newer insulins. It will be by none other than Dr. Balamurugan, sir. I would like to, Balamurugan, sir, you are online, sir?
Yes.
Yes, sir. You can share your slide, sir. Before
So you have to end the slideshow. Rohini, they have to end the slideshow. Yes.
End the slideshow.
Right.
Madam Balamurugan, sir, slide.
Checking it.
Share your slides.
Yeah, I'm just checking the slide.
So,
yeah. For a second.
Yes. Before I think I'd like to introduce the next speaker for the day on newer insulins, Dr. Balamurugan Ramanathan, sir, who's the chief diabetologist at Kovai Diabetes Specialty Center and Hospital, Coimbatore. He has done his undergraduate master degree, everything from Madras Medical College. And after that, he was assistant surgeon at a government primary health center at Nandivaram, Kanchipuram district. Then he was assistant professor of medicine at Coimbatore Medical College in between 95 to 96. And now, since 1995, he is the chief diabetologist and head of the Department of Diabetology at Kovai Diabetes Specialty Center and Hospital, Coimbatore. Sir, now the screen is yours, sir.
Okay. Yeah, good evening, everyone. At the outset, I would like to thank the state IMA CGP office bearers and Dr. Bhavadarini, my colleague and close friend, for asking me to join this meeting and share my views on the newer insulins, which has come recently, and the newer insulin, which is on the way. It's going to come in near future. So I'll try to address both of them in 20 minutes. And I pay my respect to my professor, Dr. Seshia, at this time, who have been really giving a wonderful talk. And I thank all the colleagues also joined here today in this evening. So we are going to just discuss on the clinical perspectives of diabetes management with the new generation insulins. And every one of you know that the discovery of insulin is almost a century before. Banting and Best discovered as early as in 1920. Since then, insulin have undergone several drastic transformations from animal recombinant DNA insulins than to analogs. And even though the insulins have modified and the newer insulins have come, and but yet insulin initiation is often delayed in the real world practice. Many a time we have find there has been a definite resistance or residency or a barrier in terms of insulin initiation among the patients and the healthcare professionals involved in managing diabetes day to day. And so what are the reasons for that? Many a time when you start on insulin, the patient feels that they have a sense of failure, they lose independence, and it interferes with the daily activity like meal planning and physical activity. Some people say it has got a weight gain. Sometimes people feel that it has got hypoglycemia. And so all the things make the barriers of the insulin adherence. And so when you don't initiate and intensify insulin therapy, or delay insulin therapy, we have data from the landmark studies and also studies from EDIC. When the delay in treatment intensification with insulin may result in increased risk in progression of the deleterious, both microvascular and macrovascular complications. So many times people ask the question, why should my blood sugar to be under control? What is the advantage or what benefit I get out of controlling my sugar? The landmark trials like DCCD and UKPDS have answered the question that good control of diabetes or intensive control of diabetes has definitely prevented or postponed the diabetic complications. And this again, just looking at the evolution of insulins, I think all my colleagues joined today might be knowing about it. Just want to tell you that 1922, the insulin first clinical use, then later we have added become the NPH insulin, 1940 later, then 1953 lente insulin, then biosynthetic human insulin 1982, then we had 1996 rapid acting insulin analogs, and later long acting insulin analog way back in 2000, then 2006 Exubera inhaled insulin came and was done next year itself, then the insulin degludec long acting insulin analog, then the biosimilar insulin glargine, then Afresa inhaled insulin 2015, and then later came the fast-acting insulin aspart and glargine U300, then the polyethylene glycated insulin PEG, and recombinant insulin plus all are in the vogue. The smart insulin, these insulins are on the vogue and going to come now. And this again, just looking at the various action and types of insulin. We have a short-acting regular insulin. We have ultra-rapid insulins, like most of the inhaled insulins are the bolus insulins only. And we have rapid, the Lispro, Aspart, and Glulysin. And we have long-acting Detimer, Glargine U100, Glargine U300, and insulin degludec. And this is again this list of insulins available. I think most of you might be aware the trade names. I'm not talking about a particular company. There's various trade names. When you find in the practice, you might know that we have one short-acting insulin analogs on longer-acting insulin analogs. Okay, we know rapid, Humalog, and now Limjo. All are short-acting insulin analogs. That's insulin aspart, insulin glulysin, and insulin lispro. And we are going to have a Zultofi soon, the combination of liraglutide with degludec, and we are long-acting, the glargine U100, glargine U300, and Levemir, and as well as the insulin degludec. Usually, all of you should know that standard strength of insulin is 100 units per ml now, and some insulins are concentrated insulins which are available. So again, the list of insulins which are available in the market. Then let's talk about the prandial insulin. What is expected from a new prandial insulin? So it's very important that we are today talking about the 1 hour postprandial blood sugar rather than the 2 hours postprandial blood sugar. Should be able to control 1 hour postprandial blood sugars, and to avoid the hypoglycemia at a later stage, we are using the short-acting insulin analogs, as I already said the names of them, and almost it provides a more closest to the physiological glucose control. Each is the patient burden by allowing dose as per most common pattern seen in the real world setting, dosing at the start of the meal, and increase the patient's TAR. What is the TAR? TAR is the one, the time in range, the percentage of the time throughout in a day the patient spends the glucose under control. This is one of the important concepts coming up. Probably we'll be talking in the later some other meeting about it. But we can do that by doing this ambulatory blood glucose profile using the Freestyle Libre and Freestyle Libro Pro. So these are one of the Lispro insulin, ultra rapid acting insulin newly discovered. This is actually modification of the Lispro. They added two excipients. One is a treprostinil and citrate. The citrate increases the local vascular permeability. On the other hand, the prostacyclin analog, that is one other one, causes local vasodilation. This is a treprostinil. It's a local prostaglandin analog, causes local vasodilation without causing systemic vasodilation. When you inject this Lispro, what happens? The conversion to hexamer to monomer takes place. Here you can see the absorption makes it very faster. Okay, so it became ultra rapid acting. So these are all called designer insulins. So there is one of the important advantages with these insulins is you have a mealtime flexibility. Suppose when you compare a regular insulin, you give an injection, and suppose your meal is delayed. What happens? Or you take less quantity of it, there is a possibility of hypoglycemia. Here, there's an advantage. You can just have the injection and have the meal. And in between your meal also, you can have the short-acting insulin analogs. And now even after 15 minutes after eating also, you can have this insulin according to the quantity of food. These mealtime flexibility is one of the major advantages with these short-acting insulin analogs and ultra-rapid-acting insulin analog. Then came the basal insulins, insulin glargine U100. And I'm sorry because the graph is not coming in this. Insulin glargine U100 and insulin detimer were developed to overcome some limitation of the early basal insulins, such as NPH insulin, which is less variable absorption and longer duration. Even that insulin had a smaller peaks. Then we have developed that glargine 300 per ml and insulin degludec, since they have been developed with the less variability and more prolonged duration of action. Very, very important thing is these insulins almost act for a longer time. Almost they have worked for more than 24 hours. And they have the variability, the glycemic variability. We look into both intraday as well as interday variability is less when you look at the insulin glargine U300 as well as insulin this degludec. And the crazy ideas 15 years back now become a standard of today. Rapid acting insulin analogs, long acting insulin analogs, GLP-1 analogs, continuous glucose monitoring system. When we are students in medicine, 25, 30 years back, this all looking very, very crazy ideas. Now they have come into the practice. None of these diagnostic therapeutic action were on the market 15 years ago. So we are going to be in advances in insulin. We are going to talk on the basal insulin, degludec, glargine U300, and the co-formulation IDEC aspart, as well as the mealtime insulin. There's newer aspart, okay? And the insulin delivery systems also we are just going to go through. And why do we need newer insulin? Suboptimal insulin experience steer the patients away from the good glycemic control. So we need newer insulin. So when you look at the basal insulin, I already said the glargine U100, then later came glargine 300 with less intraday and intraday variability. This is now the degludec act. How does it act? Okay, the model of hexamer formation. Insulin degludec for injection is a zinc phenol formulation as dihexamers. Okay, when you inject it, the rapid phenol depletion after injection, exposing the core and zinc ions, and multi-hexamers chains are formed. Then, okay, the zinc diffuses slowly, causing individual hexamers to disassemble, releasing the dimers, then the monomers. The monomers are absorbed from the depot into the circulation. You can see when you look at the picture, you can very easily see the monomers are bound to albumin. Almost more than 99% are protein depot. And this is about degludec, and this is about glargine U300. Here, it's a concentrated insulin, like the release rate proportional to the surface area. It's a compact depot formation, results in more gradual insulin release with the glargine 300 and 100. You can see the upper one is the glargine 300, and the below one is a glargine U100. The smaller volume, more compact subcutaneous depot with smaller surface area, more gradual and slower release from the depot surface. This is again the newer insulin, and we are going to talk about the other insulin. That is the PE glycated Lispro. the polyethylene glycated lispro. We are going to know about it. This is about the volumes. Okay, when you use 100 IU insulin, your volume what you are injecting so is less. So people who need higher dosage insulin, it's quite useful. And this is again, we talked about insulin degludec, long-acting insulin, long analog indicated to improve glycemic control in patients with type 1 and type 2 diabetes. This is, I said, the multi-hexamer soluble, slowly converted into monomers. So for most patients, changing to the basal insulin to the degludec can be done unit to unit basis on the previous basal insulin dose. This is again the polyethylene glycated lispro, which also alters the mechanism of action, and this large hydrodynamic size. Okay, this PEG lispro. Okay, and a prolonged duration of action related to a delay in insulin absorption and reduction in clearance may mimic physiological ratio of hepatic peripheral activity of endogenous insulin more closely than other exogenous insulin. Most all of you might know that when you inject insulin subcutaneously, that it might cause some peripheral hyperinsulinemia. It may not exactly undergo the hepatic clearance. So normally, like a portal venous insulin secretion, these insulin might closely mimic physiologic ratio of hepatic peripheral activity of the endogenous insulin other than the other exogenous insulin. Okay, and in contrast, the activity of other exogenous insulin is distributed equally across liver and peripheral tissues. And again, this basal insulin pharmacokinetic, I said, when you look at the onset of action, almost similar, but when you look at the duration of action, the glargine 300 is almost 24 hours. These degludec is more than 42 hours. The PEG lispro more than 36 hours. Okay, that's very, very important. And we have the U500 regular insulins. It's a concentrated form of regular insulin. Can be used to control hyperglycemia in severely insulin-resistant patients, usually requiring more than 200 units per day. And the U500 insulin has been used successfully in patients with obesity, immune-mediated insulin resistance, and genetic abnormalities of insulin receptor. There are some genetic syndromes you can see in children where there is a genetic abnormality and the receptor insulin resistance with diabetes. There are some syndromes described on that. They require high volumes, high units of, larger units of volumes and units. So these insulin is quite helpful for them. And this is very important. There's a new once-week insulin icodec. The molecular modification underlying the longer half-life. One is 3 amino acid substitutes prevent enzymatic degradation, ensure stability and solubility. Second, addition of a C20 fatty diacid imparts strong and reversible albumin binding, and all modifications contribute to slow receptor-mediated clearance. The icodec interacts with insulin receptors to activate the same signaling pathways to give you the same full metabolic effect as human insulin. Icodec does not demonstrate increased binding of to the IGF receptor and is low mitogenic potential. Very, very important when the insulin gets binded to the IGF receptor, there's a possibility that it can be mitogenic. So these icodec insulin does not demonstrate increased binding to the IGF receptor. So obviously low mitogenic potency. That's very, very important. The gradual continuous release of icodec from albumin-bound depot leads to prolonged action and is expected to reach the steady state will occur in 3 to 4 weekly doses, at which time the full glucose lowering effect of the given icodec dose will be achieved. The slow release of albumin-bound icodec combined with slow receptor activation is expected to buffer against the dosing variation. If you take suppose 6 hours, 10 hours delay in a weekly dosage of injection, it doesn't matter. Once the steady state is reached, this can be, the therapeutic effect occurs. Again, what are the various methods to improve the insulin absorption? What are the intradermal insulin injections, the BD and US, smaller, more shorter needles, less pain, more rapid absorption, addition of excipients that keep insulin molecules monomeric, the Biodel, addition of excipients that improve absorption, like halozame insulin, local heating of injection site is also on the wound. This is called the area, alternative routes for insulin application. Aim to optimize pharmacodynamic, pharmacokinetic properties, optimization of the metabolic control, early start of insulin therapy in patients with type 2 diabetes, avoidance of other disadvantages such as subcutaneous insulin like cooling of insulin, non-physiological application. So what are the area? You must know that the red dark lines indicate that they're in the current use or on the imminent use. Okay, the buccal, oral insulin, oralin, and eye intraperitoneal, intravaginal, intravenous insulin administrations, the nasal, oral, and pulmonary, the technosphere insulin, the rectal and scrotal and transdermal. So there are the dark red lines are all almost in the coming to the current use and their imminent use. And this oral pill insulin, convenient of use, better compliance, physiological insulin delivery, better control of hepatic glucose production. One of the important point is the first pass hepatic insulin extraction means the less peripheral hyperinsulinemia. I already said, whenever you inject more insulin, whenever there's insulin resistance, also there's hyperinsulinemia. When you give more injections, also more volume, more units, there might be peripheral hyperinsulinemia. This is avoided with this. What about inhaled insulin? This ultra rapid acting insulin, peak levels are achieved in 15 minutes and less weight gain, hypos than the others, address issues of dexterity and phobia, contraindicated in chronic lung disease. It's mostly is a bolus insulin. Okay. In fact, I'm happy to share with we have also recently conducted a phase 3 clinical trial with the inhaled insulin, and we are waiting for the results. And the spirometry we have done in the baseline 6 months and then annual. Now the side effects being cough and throat irritation. Do not use in patients with active lung cancer. Use with caution in patients with the history of lung cancer or at the risk for lung cancer. This is called technosphere insulin. Technosphere formulation is a technology is centered on a class of pH-sensitive organic molecules that self-assemble into small particles under mildly acidic conditions. Certain drugs such as insulin can be loaded onto these particles by combining a mildly acidic solution of the drug with the suspension of technosphere material, which is usually a dried to a powder. When the particle contacts the moist surface of the lung with its neutral pH, the technosphere particles dissolve immediately. This releases the insulin molecules, which then diffuse across the thin layer of cells into the bloodstream. Studies indicate that insulin absorption is a passive process that occurs without disruption of either the cell membrane or the tight junction between the cells. This is Pep277 is a 60 derived peptide under development by Andromeda Biotech for the treatment and prevention of type 1 diabetes. The newly diagnosed or established disease with some remaining endogenous insulin production and people with LADA. Okay, it acts by specific modulation of the autoimmune responses from the pro-inflammatory type to an anti-inflammatory type. It converts from pro-inflammatory autoimmune response to anti-inflammatory type to maintain residual beta cell function and halt the disease progression. This is what the spectrum of options we had. From the started with the conventional insulins, we moved on to the intensive insulin therapy. Then now the insulin pump therapy, sensor augmented pumps, and artificial pancreas is on the vogue. So I try to take you through some newer insulins which are available in the market and the insulins which are going to come in the near future to all the use of used by the patients and by our healthcare professionals. Thank you very much. Can we take up some questions on this now?
Balamurugan at the end.
Thank you, sir. Balamurugan sir, we'll take questions at the end all together, sir. If you start now, it will get delayed, sir. Thank you, sir. Thank you for your elaborative and short and sweet lecture, sir. Next topic will be by none other than Dr. Panneerselvam, sir. Sir, I would like to introduce Dr. Panneerselvam, sir. Sir, you can share your screen, sir. Yes. Dr. Panneerselvam, sir, completed his MBBS from Chengalpattu Medical College, MD General Medicine from Stanley, and Diploma in Diabetology from Madras Medical College. He was formerly the Assistant Professor of Diabetology at KMC, Chennai. He is the Managing Trustee of Aruna Diabetes Research Foundation, Chennai. He is also the Chairman, KRS Insulin Bank for Juvenile Diabetics, Co-Chairman, Diabetes Association of India Southern Chapter, Vice President, Research Society for the Study of Diabetes in India, former project coordinator with the World Diabetes Foundation and Gestational Diabetes Wellness Project in Tamil Nadu, contributed original articles on diabetes in international and national journals. He is also the recipient of Diabetes Awareness Initiative Award, Diabetes India 2015. Sir, the screen is here, sir.
Right. Could you able to see
some recent updates in diabetes?
Could you able to see my screen?
Yes, sir. You are able to see the screen, sir.
Right. Right. Thank you for IMA Tamil Nadu branch and College of General Practitioners, and thanks to Dr. Bavadarani, our colleague, and my previous speaker, our Professor Dr. Sheshaya, as well as Balamurugan, who elaborated well on primordial prevention as well as on the neuroinsulin therapy. My topic today is recent update in diabetes. Of course, everything is getting updated every day, so diabetes is not having exemption. But unless otherwise, we update our knowledge also about any specialty. So diabetes is an important specialty. I am going to highlight only the certain areas of update: epidemiology, pathology, pathophysiology, management, monitoring, and conclusion. So what are all the changes happened in the epidemiology? Epidemiology in 2000, International Diabetes Federation assessed about 150 million of people in the country or in the world is affected by diabetes. They have projected to 2025 as 300 million. This projection was estimated 97. Whereas in 2021, instead of achieving 300 million at 2025, the world achieved 366 million in 2011 itself. Otherwise, diabetes is fastly growing all over the world. In 2021, 537. In 2025, we may cross 600. Otherwise, earlier, they have predicted 2025, 300 million. By 2025, almost we are going to touch double the prediction. So the prediction is going wrong. Otherwise, the diabetes is growing very fastly all over the world. In particular, in our country, in 95, they have estimated 19.4 million of the people are affected with diabetes. In 2025, it is getting projected as 57.2 million. 2025, 57.2 million, whereas in 2021 itself, India is touching 74 million. In 2045, India will be touching 124 million. So that only the all over world, diabetes is on increase. In India also, diabetes is on increase. So we are sensitizing all the doctors all over India through various measures. This is one of the virtual meeting is one measure, and RSDA also doing, Diabetic Association, Diabetes India, and so many organizations are keep on doing. But unfortunately, still we come across a lot of undetected cases, uncontrolled cases. In South, this is National Family Health Survey in 2019. South predominantly more cases, 20 and 27. So when compared to the rest of the country. This is recent information, 2023 information. Out of 113,000 people screened, 79,000 from rural area and 33,000 from urban area. So diabetes 11.4%, pre-diabetes 15.3%, hypertension 35.5%, generalized obesity 28.6%, abdominal obesity 39.5%, dyslipidemia 81.2%. This is ICMR study. Of course, Dr. Mohan Center took up all over India and passed on the message that non-communicable disease, metabolic non-communicable disease, so that only if you come across diabetes, it is better to evaluate for hypertension, better to evaluate for dyslipidemia, as well as obesity. Unless we correct all these parameters, your cardiovascular, renal, or other complications cannot be avoided. The increasing frequency, earlier onset, and greater severity of childhood obesity. This is another area we do come across now for the past 10 or 15 years. Childhood obesity is becoming more common, especially after COVID, especially after the arrival of smartphones and computer, cell phone, laptop, palm top, etc. The physical inactivity drastically came down from the childhood. The childhood obesity is keep on increasing, together with increasingly sedentary lifestyle and increasing frequency of intrauterine exposure, which our professor highlighted, intrauterine exposure of blood sugar. If it is more than 110, he has clearly repeatedly told throughout his lecture for 20-25 minutes, it should be always less than 110 postprandial. Unless otherwise we maintain this less than 110, they are going to develop diabetes. The child also going to develop diabetes. The mother also going to develop diabetes. We are going to prevent diabetes in 2 generations. So intrauterine exposure to diabetes are important drivers of epidemic of youth onset type 2 diabetes. This is again 23 informations. So these are all the causes. From childhood onwards, we have to concentrate. So that now we have given to the government also, like your Red Ribbon Club for AIDS, we are going to give Blue Circle Club for diabetes to highlight about importance of early detection, good control, prevention to the schools and colleges. So type 2 diabetes pathophysiology, of course, in 1980, for juvenile onset diabetes, the absolute deficiency of insulin leading to type 1 diabetes or juvenile diabetes, the relative deficiency of insulin in maturity onset diabetes. While we are doing undergraduate, this was the classical definition or this was the classical information for diabetes. In 98, impaired insulin secretion from the pancreas, increased hepatic glucose output, decreased glucose uptake. This is triumvirate, 3 causes for hyperglycemia. Then subsequently it has become cetaxide sexate. So another 2 classes added. Recently in 2009, so omnious octet, decreased insulin incretin effect, increased lipolysis, decreased uptake, increased glucose absorption, neurotransmitter dysfunction, increased hepatic glucose output, increased glucagon secretion, and decreased insulin secretion, 8 classes. So now for 8 classes, we have drugs also. So that only single molecule may not correct these 8 causes which are giving hyperglycemia. We have had to go for combination therapy to correct hyperglycemia early in the management of diabetes. Of course, recently, this is 2022 information, 12 pathophysiological defects for type 2 diabetes. This is otherwise called the deleterious dozen, 12 pathophysiological defects. So they have added immune function and chronic inflammation, gastrointestinal, they have added few more. So 12 causes, but whatever the number of causes, better to prevent diabetes or detect diabetes early, revert it back to normal or keep it well under control to avoid complications of diabetes. Of course, UKPDS taught us in 99, at the time of diagnosis of diabetes, almost 50% of the beta cell has lost. This is Lebowitz concept in 99. In 2004 or 2006, by the time of diagnosis of diabetes is made, the patient has lost 80% of the beta cell function. Of course, after 2006 or after 1999, now we have a lot of understanding about diabetes, lot of newer molecules also. This was earlier understanding while we were using sulfonylurea, insulin, metformin for treatment of diabetes. Now we have alpha glucosidase inhibitors, DPP4 inhibitor, pioglitazone, gliptins, gliflozins. All these molecules are helping the patient or helping the doctors to retain the remaining beta cells. Further loss of beta cells can be prevented by the modern drugs because all these observations were made with the earlier molecules like insulin, sulfonylurea, and metformin. So the management of type 2 diabetes before the year 2000, as I have told you earlier, we had only sulfonylurea, metformin, and short-acting intermediate insulin. Now we have plethora of molecules. We have acarbose, megalithol, oglibose, TSZD group, DPP4 group, and a lot of non-insulin parenteral like exenatide, liraglutide, dulaglutide, GLP plus insulin, and a lot of gliflozins, a lot of newer molecules we have in the management of diabetes. Of course, we have to know the pharmacokinetic and pharmacodynamic of each molecule, and various companies with various combination, various trade names started marketing after patency had gone. Now the practitioners are getting confused, even diabetologists are getting confused due to so many names and so many combinations and so many strengths. So earlier treatment, glucosamide, insulin, diet, metformin. This was the available management for diabetes in 1999. So whatever we give, initially only A1C comes for 1 or 2 years. Then from 3rd year onwards, A1C keep on rising. So how to pull down the A1C and maintain the A1C was the big question before the year 2000. Now after the arrival of all these newer molecules, we could be able to pull down and maintain the A1C. This invited all complications of diabetes despite treatment. But of course, Wikipedia taught us each 1% reduction of A1C will reduce so much of microvascular complication, 43% of amputation, 21% of death due to diabetes, 14% heart attack, and 12% reduction in the stroke. Each 1% reduction will definitely give benefit. This positive message also we obtained from UKPDS, which was conducted from 77 to 97, 20 years, all new cases they have recruited. Again, UKPDS taught us sulfonylurea and metformin resulted from progressive beta cell failure. Not only UKPDS was designed as monotherapy study, all the guideline also initiating treatment for diabetes with monotherapy. But that will not protect the beta cell and revert the pathophysiological defect behind type 2 diabetes. This is 2015 information. And of course, up to 2017, the guideline after lifestyle modification, metformin, sulfonylurea. From 2018 onwards, only sulfonylurea is taken out. Then your DPP-4 inhibitor, other molecule came in. And ADAPT trial also, when compared to metformin, rosiglitazone, glyburide allow the A1C to go high once the duration goes. The annual rate of decline in HOMA beta was highest with the sulfonylurea, that is 6.1 versus metformin 3.1, TZD, that is rosiglitazone they use 2, ultimately mirroring a lack of beta cell survival in case of sulfonylurea. Again, this study also various study, whatever sulfonylurea we use, initially the A1C comes down, then A1C keeps on rising. So, and what we are doing now also, instead of pulling down the A1C and maintaining the A1C, initially our patients are responding for treatment or coming regular for treatment. After that, they don't come for treatment or they lose control. The hyperglycemia sets in. Then the risk of complication continues, bad glycemic legacy. Already this glycemia started spoiling all the organ in the body. Even if you pull down the A1C to normal and maintain, the already damaged organ is not getting corrected. Sulfonylurea and glycinide, the message is both sulfonylurea and glycinide fail to prevent the progressive beta cell failure that is characteristic of type 2 diabetes. Sorry, this is another information also. HbA1c progressively increased, and after 10 years of majority of the subjects required insulin therapy if you use sulfonylurea and metformin alone. And sulfonylurea are no longer justified as second-line therapy, which I have shown you in the 2017 ADA guideline, no longer justified as second-line therapy, so that only sulfonylurea, they have brought it back to last bench. No to sulfonylurea. This article says in 2023, sulfonylurea and glycinide should not be recommended for the treatment of type 2 diabetes. Or if at all you want to use sulfonylurea, use modern sulfonylurea like glimepiride and glycoside, that to lower dose, glimepiride 1 milligram or the maximum 2 milligram per day. Not 2 milligram BD. 2 milligram BD will spoil the remaining beta cell or invite hyperglycemia, will cause gross glycemic variability, will invite CV risk also. Similarly, glycoside also, minimum 40 milligram BD to maximum 80 milligram BD, not more than that. Otherwise, minimize the use of sulfonylurea because newer molecules are helping the patient to control diabetes. So that really this article says this guideline should not be recommended for treatment of type 2 diabetes. So what are the drugs then available along with the metformin? Along with the metformin, we have alpha glucosidase inhibitors, thiazolidinediones, DPP-4 inhibitor, SGLT inhibitor, GLP-1 receptor agonist, and insulin analogs. These are all the various class of drugs introduced after the year of 2000. For the past 15 years or 20 years, we have these molecules, and we have sufficient experience also. Most of the molecules are safe. We know the mechanism of action and adverse effect also. Accordingly, we can control diabetes without causing hypoglycemia. So let us shift the management of type 2 diabetes from control of disease and the treatment of its complication to prevention of disease and arresting the further progressive loss of beta cell. Retain the remaining beta cells, give relief to the remaining beta cells, save the remaining beta cells, allow the individual to live with the remaining beta cells. So after the year 2000, pioglitazone helps. TZD increases the C-peptide concentration, reflecting improvement in beta cell function. TZD induces preservation of beta cell function. TZD regenerate beta cells, in addition to improving insulin resistance and glycemic control. Is compelling reason to use this agent as initial therapy for type 2 diabetes. Of course, this information 2003. But in between 2013, there was a Galata for bladder cancer issue, but it was nullified for now almost 10 years over after bladder cancer issue. Then we are using continuously. We are using pioglitazone from year to year 2000. Before bladder cancer issue also, after bladder cancer issue also, we are using the pioglitazone. So far, we have not come across any bladder cancer. If at all we have problem, edema, weight gain. And for cardiac failure patients, we should not use this molecule. So for your cardiac failure, better avoid this molecule. Along with the insulin, it worsens the edema or it worsens the cardiac failure. Along with amlodipine also, we have to be very cautious. Otherwise, this molecule is a safe molecule. They regranulate the beta cell. This is degranulated beta cells. Once you use pioglitazone, they regranulate the beta cells. So beta cells started secreting insulin naturally or normally. Pioglitazone, the forgotten cost-effective cardioprotective drug for type 2 diabetes. This is D. Franco's statement, year 2019. Early intervention will be required to ameliorate insulin resistance, prevent beta cell failure and loss of beta cell mass, maintain normoglycemia, and prevent microvascular complication, which do not occur if the A1C is less than 6.5. So A1C must be 6.5, for which we have to address from the insulin resistance itself. Prevent the beta cell failure. Simply writing the medicine by looking at the number is one component, but we have to prevent the beta cell failure and prevent the loss of beta cell mass also. This means that improved diagnostic tools will be required to identify high-risk individuals for the development of diabetes and CV events at the pre-diabetic stage itself. That is insulin resistant stage itself, we have to educate the patient. This is 2002 information, D. Franco. So lobeglitazone is a new molecule, 12 times higher binding affinity when compared to Rosi and Pio. Of course, it has equal potentiality. Fasting blood sugar, lobeglitazone base 8.5. After 24 weeks, 7.3. Similarly, for pioglitazone 15 milligram, 8.6, 7.2, and almost equal to your pioglitazone. So lobeglitazone also you can clinically use. So based on the study summarized in this presentation, lobeglitazone is a novel TSLD with potent efficacy and favorable safety profile. Lobeglitazone shows similar glycemic efficacy to pioglitazone with a lower effective dose, moving to its higher affinity to PPR gamma. We are using this molecule since 2 years. Alpha glucosidase inhibitors in the market from 1997. So it inhibits the pancreatic amylase. So by which disaccharide is not getting monosaccharide, converted to monosaccharide. The fasting blood sugar and PP blood sugar, blue color is metformin. Here combination of acarbose and metformin. So the PP reduction, A1C reduction much better when compared to metformin. And insulin sparing effect also. It has insulin sparing effect, no hypoglycemia, no weight gain also. And in addition to blocking the absorption of glucose, it improves the GLP-1. Acarbose improves the GLP-1. This elevated GLP-1 along with the DPP-4 inhibitor and metformin persistently helps the beta cell to go for its original synthesis of insulin. So without glycemic variability, the blood sugar is beautifully getting controlled if you combine acarbose with the metformin and DPP-4 inhibitor. Of course, ADA in 2018, alpha glucosidase inhibitors are not used commonly in the USA and some are not licensed at all in Europe. So because of this, they are not using. But unfortunately, our country people also not using acarbose or alpha glucosidase inhibitors. But China, India, Japan, all Southeast Asia is using, I could say, almost 60% of the world population is using alpha glucosidase inhibitors. What they say is no major new scientific information on this medication has emerged in recent years, so they don't want to use, but our country is using, especially we are all using for more than 25 years, it is giving beautiful effect. They have mentioned only one line about alpha acarbose and meglitol. They have not mentioned about voglibose in their guideline. However, there is currently no evidence that a single medication or combination has durable effect for many patients. Injectable medications become necessary within 5 to 10 years. Of course, this statement in 2018 statement, now we could able to make the patient to live with the diabetes without insulin, injection insulin, even for more than 15 years, 20 years. Of course, their guideline, what they say is we attempt to provide an approach that summarizes a large body of recent evidence for practitioners of United States and Europe. ADA and ESD guideline for practitioners of US and Europe. Of course, we can learn globally, but act locally. We need not apply ADA guidelines strictly for Indian population. Indian population is different. Our dietary habit, our body mass index is different. Let us not strictly follow the Western guideline. Voglibose, same mechanism of action. DPP-4, of course, all of you aware, DPP-4 lowers A1C by increasing plasma GLP-1 and GIP, both combining. So the vildagliptin plus metformin, GLP-1 level is at higher side. Along with alpha glucosidase inhibitors, some more potentiality of GLP-1. As I have told you earlier, recent studies have implicated GLP-1 in regulation of beta cell violation, alteration in the autophagy signaling in both pancreatic cells. And DPP-4 demonstrated durable effect on pancreatic islet cell mass insulin content, while this effect was not seen in the sulfonylurea. Combination treatment of DPP-4 inhibitor, thiazolidinedione, alpha glucosidase inhibitors resulted in increased pancreatic insulin content compared to either agent alone. So increased insulin pancreatic content. So when compared to sulfonylurea, degranulated the beta cell. Insulin content is lowered, but here the insulin content in the pancreatic beta cells are getting improved. Of course, GLP-1 analog again increase insulin and reduce glucagon secretion, inhibit basal hepatic glucose production. This is in use for now from 2005 onwards. Liraglutide beta cell function is getting improved. Oral form of semaglutide also available now. So two diabetic drug classes maintain the beta cell function. There are only two drugs that will increase beta cell function and preserve the increase on long-term basis. Defranso again, they are pioglitazone and GLP-1 receptor agonist. I know people are reluctant to use pioglitazone. I have used it since 1990. It is fantastic drug. Even with advanced disease, these two drugs will work. This is a statement in 2021 by Defranso. So now the treatment have totally changed. When compared, as I told you earlier, before 2000, the available drugs were not effectively controlling diabetes. Now the available drugs are helping the beta cell to retain the remaining beta cell and secrete insulin physiologically. SGLT inhibitor, again, all of you are aware how it acts, and it has also changed the modality of treatment. Of course, small drawback is there, urinary tract infection, vulvopastitis, vulvovaginitis. Very rarely they develop pyelonephritis also. Some of them are developing DKA also. We have to be very cautious. Otherwise, we have to rewrite diabetology. Earlier trials, references, etc. were based on the insulin, sulfonylurea, and metformin. These three molecules only were used along with lifestyle modification from 1923 to 2000. From the year 2000, we have a lot of newer molecules like AGI, TZD, incretin, GLP-1, SGLT inhibitor, imiglimine, and HIQ. These are all the newer molecules helping the practitioners as well as the patient for maintaining good control. A combination approach focusing to correct insulin resistance, beta cell secretory defect, and hyperglucogonemia seems to be superior and safer than sequential therapy with metformin, sulfonylurea, insulin that does not reverse underlying pathophysiological defect in type 2 diabetes. So imiglimine is a new molecule. Single dose administration of imiglimine enhances insulin secretion in response to glucose from the beta cell and reduces blood sugar. Imiglimine exerted favorable effect on the morphology in beta cell mitochondria, increased insulin granules in beta cells, reduced apoptotic beta cell percentage. So the total insulin content in the imiglimine arm is much better, 9.6 when compared to 4.5. Total insulin response was 112% higher with imiglimine than with the placebo. Of course, imiglimine also in use for the past 1.5 years. We are using it now. To summarize about imiglimine, imiglimine acts on the root cause of diabetes by correcting mitochondrial dysfunction. It does not affect mitochondrial respiration. Unlike metformin, add on to any oral antidiabetic drug or insulin. It has effects beyond diabetes, reactive oxygen species reduction, and cardiorenal protection, less lactic acidosis compared to metformin. Tirzepatide is available in UK, USA, but in our country it is going to come. Tirzepatide is a novel combination of GIP and GLP receptor analog. Of course, A1C for 5 mg, 10 mg, 15 mg, when compared to placebo arm, A1C reduction less than 0.5, 5.7 physiological range without hypoglycemia. Similarly, weight reduction also much more effective, 37%. So weight reduction plus HbA1c reduction superior with this molecule. Of course, this is not available in India. And tirzepatide percentage of adults maintained good control, 93% when compared to placebo arm. This I will skip. With the dual agonist like tirzepatide or even triple agonist like retatrutide, patients can lose significantly more weight than with the monoagonist, that is semaglutide. Gastrointestinal events were also frequent in studies in the dual agonist. This is the only side effect. But if you overcome this side effect, this molecule seems to be good for obese people, obese uncontrolled people. FDA approved this molecule on 13th May 2022. Central Drug Standard Control Organization, India, New Delhi, gave green signal to Lilly to market in India in 21st April 23, but they have not marketed still. We do not know why. Agents that increase the preserve the beta cell function. That should be the aim of all of product, whether you are general practitioner, budding practitioner, or specialist practitioner, whatever specialty will be, because everybody is prescribing now anti-diabetic drug. So by looking at the number, writing some brand is one component of treatment. We should know the pathophysiology behind each patient and pharmacokinetic and pharmacodynamic and adverse profile of the various drugs. Aim is we have to preserve the beta cell. So remaining beta cell must be preserved, for which the newer drugs are all helping. Of course, insulin, Dr. Balamurugan elaborately dealt from 22 to 2017. Yes. And sorry. So future insulins, these are all the future insulins. So monitoring also changed from urine sugar, blood sugar, and self-monitoring. Now we have continuous glucose monitoring. This is the continuous glucose monitoring probe is in the capillary. From capillary, blood is seeping and sugar is here. When before it goes to cells, it senses, the sensors are sensing. And of course, now the sensor is assessing the blood sugar, transmitting the blood sugar to the pump, insulin pump. Accordingly, the insulin pump infusing the blood. Now the technology has gone to this level of monitoring blood sugar and maintaining the blood sugar. The sensor is sensing the blood sugar and sending the report here. Accordingly, the pump is injecting the insulin. I will end with this. Of course, this sensor is 180-day sensor is going to come. They are going to implement that sensor. Is only 15-day sensor. This is 6-month sensor. Of course, from treat to fail approach to, we have to persistently maintain the blood sugar by acarbose. This is by acarbose. This is by gliptins. This is by dapagliflozin. We can pull down and maintain the blood sugar in modern treatment. This is one of our case. A1C was 10.8 from 2002 onwards. Almost 20 years we are maintaining the A1C without going high. This is very much possible by modern treatment. Thanks for opportunity to IMA College of General Practitioners as well as my colleague Dr. Bavadarani. We will take up the question at the end. Thank you.
Thank you, Paneerselvam sir. There's an elaborative lecture on the recent updates. Thank you, sir. Now I request Dr. Gopalakrishnan sir to introduce our last speaker and coordinator, Dr. Bavadarani madam, for the last talk of the day. Gopalakrishnan sir. Dr. Gopalakrishnan sir, are you online? Gopalakrishnan sir. Okay. So I think sir has some problem with the network. I'll introduce her myself. Dr. Bavadarani madam, you all know she's the coordinator for our FCD course for a long time. And she has been the honorary professor of diabetology with the state IMA. She has been conferred the best teacher award by our state IMA. She is also the faculty in diabetes training program in DPH in Tamil Nadu government. She is also the state coordinator for diabetes for the IMA course and regional coordinator for the WF. So, madam, the screen is yours, madam. You can just.
Thank you, doctor. I immensely thank IMA for this wonderful opportunity. Coming to the topic, you have heard well about the pharmacotherapy, insulin, as well as the recent updates, everything. Now, I am coming to the very important part. Please concentrate. This is the lifestyle upon which you can build everything. You know, diabetes capital of world is India, and this is increasing every year. You heard from all my speakers, previous speakers, and every 8 seconds a person dies of diabetes. The same 8 seconds, 2 people develop new diabetes. You have to stop this clock. Not only the drug, you should also do adequate exercises and proper diet along with regular checkups. For all this, you need education, which I am going to say what all to be done. We are thrifty genes. Our genes have not changed for the past 1 lakh years, but we have changed from a primitive nomad to a sophisticated modern man. especially in the urban areas. Not only in the urban areas, it happens everywhere, rural or urban. You're not able to find out the rural area. Of course, we were searching for a single meal, fighting for a single meal a day, wandering here and there those days. But now the food is available everywhere, 24/7, and most of the time, 18 hours when the man is awake, he keeps on eating and munching something. Not only that, he was walking for everything, struggling for food, but now everything, he goes by wheel, he moves on wheel. Even for the rural areas, the village people, the mini bus and the share autos, they pick up and drop them at the store step. And food, fast food, it is available according to your purse, whether it is on the roadside or in 5-star, everywhere it is available. What is the gain because of this change in lifestyle? Of course, we have a sophisticated living conditions. We got a variety of foods, easy transportation and communication. Of course, by our constant efforts, we have eradicated all the communicable diseases, but we have made the non-communicable diseases by more eating, less physical activity, and some stress always. So we are landing up in more obesity, diabetes, hypertension, and cardiovascular diseases. I think you all will agree with me. And what diet and exercise I'm going to say is not only for diabetes, it's for anyone, young or old, male or female, diabetic or non-diabetic, pregnant or non-pregnant. This is the perfect diet for anybody. It's very easy. There is no special diet for diabetics. Only thing you need to avoid refined sugars and sweets. It's for diabetic as well as non-diabetic. And regular meal timings, proper distribution of food, and a variety and balanced diet. There is no good or bad diet, but everything in moderation. What they have said in olden days, Atral alavarindu unga. Alavukku meerinal amirthamum nanjil. So keep in mind all this. So you should take in a right time and right quantity, and also it should be of good quality. These things just keep in mind and just follow. And it should contain in proper proportion all these carbohydrate, protein and fat, the macronutrients along with the micronutrients, that is the vitamin and other things. It's easy to follow this ADA plate model, which says half the plate full of vegetables and greens, just quarter only carbohydrates, and other quarter equal to that to follow proteins. That will not raise your blood sugar, and it will not, or it will also be retained for a long time so that you won't feel hungry often. Instead, what we do, we take 3/4 plate full of idli, dosa, chapati, sadam or pongal, and take very little proteins and other nutrients. So this should be avoided, and you have to go for the proper meal plate first and foremost. This is important. Then instead of taking 2 or 3 large meals, split the same calorie into 5 or 6 and take in a frequent small quantities. And fasting as well as feasting, both has to be avoided. And it is according, if it is a children, yes, you can allow more calories because he or she has to grow. Whereas if you attained 30, about 25, you have to follow your diet according to the height, weight, age, the clinical condition, and your activity. That is very important. See, this boy is running about for a job. He keeps studying. He's not bothered about his diet. Whereas if he settles in a job, he earns more and what it's not like that. Here again, he has to say what he has been doing before he got the job. And he also should keep on reducing his diet if he doesn't want to get into all these diseases. And the calories, it's not the same for all. It is less for the software engineers and also for doctors like us who are sitting most of the time, and office workers, where it is more for players, postmen, and other very hard workers. Though it may be of the same age, it's not for both these men, and also it's different for male and female. And children, they need more calories, whereas old age, we have to cut down and slow down the calories as much as we can. If I say sugar, you all think of only the white sugar, you avoid the white sugar, but keep on taking the other things like palm sugar, jaggery, cane sugar, juice, all this, everything, honey, all will raise your blood sugar. Avoid everything. And whatever you take, it has to be put in a plate together. That is not taking one by one or very gradually, slowly. All this are not allowed. Like how they give in the hotel, it has to be kept together. 3 dosas or 4 dosas, 2 idlis, whatever it may be, along with the chutney sambar, what you take to be taken together. You should not go for the second serve. That is very important. Keep everything, whatever is given to you, in a single serve and then start eating. The scene of the thing will give you satisfaction and you'll know how much you're really taking. All grains allowed, all vegetables you can take, but fruits only and the advice of the doctor. Some patients, their blood sugar will get raised, for some it will not raise. So ask your doctor, then go for fruits. And whatever you may take, it's idli, dosa or bread or whatever, you add these greens and vegetables along with this. This should be a must for all 3 meals. That is, these vegetables and greens should form 5 servings a day. It's not just once. All these fried items, which are very tasty, which you all like very much, has to be avoided. Remember, it's only 15 ml per head in a house every day. The oil allowed. All combined oil you can use, but the saturated oil should not exceed 1/3 of what you're taking, oils together. And you can easily take that half liter per head in the house. If there are 4, it should be less than 2 liters. You can even use 1 liter, that's well and good, won't get anything. But it should not exceed 2 liters for 4 persons, just half liter per person. That is the. Coming to the non-vegetarian, the mutton, beef, pork, all these are not allowed. And again, the organ meat, liver, blood, intestine, all these are brain, all these are not allowed. And if you're taking egg, you have to take the egg white alone. If you're taking regularly, daily, even 2 egg white you can take. But if it is whole egg, it can be taken 2 or 3 per week. That you should know. And chicken, country chicken is the best, not the broiler. And fish is very good. You can take even every day, but the grilled fish, not the other one. The method of cooking is very important. You all are aware all these tobacco, smoking, snuff, pan, everything, just not smoking alone. All these habits should be stopped. Once you get, before getting itself, if you stop, you will not get it. And the milk and milk products, that's very important. It's meant only for the kids. Any animal, it gives milk only for its kids, but man is the only one which uses for everything to make biscuits, creams, ice creams, milkshakes. This is very bad. And also the aerated drinks, it contains only sugar, nothing but sugar. So that has to be avoided. And you pet your children and think that if you give all this, they like you more. Please, the grandparents and parents, do not give them all this. It not only puts them into obesity, but also other problems can occur. So avoid all this. And this, all items should be avoided. Otherwise, you'll get into obesity and all diseases, what I said. And tinned items should not be used. Make your own food and always take homemade foods. That's very important. And whatever calorie you have taken in should be let out. Energy in should be energy out. By metabolism partly, and also daily activities other than you should do extra exercises, because the females say, I'm doing the cooking all the time, I'm doing the housework. Other than that, they have to do some extra activities. And this has to start mainly from childhood. Then only anjila valayadu, ampadila valayadu. So start teaching them from childhood. Don't feed them with all the unnecessary fast foods. And before eating, if you want to cut down the calories, what you want, take some buttermilk, soup, green tea, or whatever you want. At least a tumbler of water, glass of water is adequate, because it takes 20 minutes for the stimulus to be sent to the brain that it is full. If you are just going straight away to the food, you are going to take more. Instead, take 5 minutes before a cup of liquid, something like water, green tea, whatever I said, then start eating. You cannot take more. That you should understand. And again, if they say, I'm taking rice, see what form they are taking, whether it is brown rice or white rice or biryani they are taking. They may say all this, I'm taking only bread. See if it is croissants, cakes like that, or it's just whole wheat roti or paratha puri. And if it is steamed grilled fish or deep fried fish, and green salads or salads with cream and cheese. If you say they will give you supply, if you go and ask in the hotel, they'll of course give you salads, but it won't be just salads like how we make it. they'll be spraying some creams and cheese. And again, as far as fruits, if it is allowed, you can chew and take, not the juices and shakes. You have to keep fit, not fat. That is very important. And for this, you just need a simple appliance in your house, just an inch tape. You measure your hip size. If it is 80 for females and 90 for males. If you maintain within this, you will not get most of the diseases. Remember, you carry an atom bomb in your belly. This is the Manida Vedigundu, what you carry in it. It's a female or male. Everybody has this tummy, especially the females. They have a big tummy, and that is the cause for more diseases than the females. The other thing is sitting is the new smoking. We doctors or software or anywhere, wherever you go, it's in the meeting or campaign or conference or in the schools, colleges, cinema theaters, TV, aeroplane, wherever, they continuously sit. This is not good. Smoking cigarette takes away single cigarette 11 seconds of your life. Whereas if you sit for more than 2 hours, it's like smoking 2 cigarettes, 22 seconds of your life is gone. And if you say, I'm doing some exercise in the morning, it's not adequate, intermittently you have to break your continuous sitting. That's very important. And our elders in the house and ladies in the house, they are very much used to this, always sitting in front of the TV, not just watching the TV, having something always, not knowing how much they have eaten. And take an oath that if anybody sits in front of this, should not sit in front of the TV, they should stand and watch, and they should not eat anything. That's very important. Make your children not to play with your laptop, TV, any screen like a cell phone, all this. Make them get out of the house and play outdoors. That is very important. The number of hours you sit in front of your TV is directly proportional to your tummy, obesity, and getting all the non-communicable diseases. See, you should follow something like this. When you're in front of the TV, do something and keep watching. Because if you get interested, if you want to watch a full movie, watch it along with exercise. That's very important. And you can do any form of exercise, gardening, walking, swimming, jogging, skipping, anything, whatever you like, you're fond of, you can do it. And whatever work you should be doing, it should be in a faster manner. Not that you do some exercise and keep on doing things slowly. That's not allowed. You have to. And yoga is best. If you can do yoga, keep doing it. Any yoga. And along with yoga, it's very important. You have to take a breathing exercise. That will help a lot in giving you good oxygen and help you in purifying the blood. And listen to music, visit some worship places, or go to your relatives' house, at least you mingle with your family members, share your problems and joys with the members and family members and also your friends. And the other important thing, what you heard from my mentor, godfather, now is it's the genetic. By heredity, we may get the disease. It may be, I don't think it is transmitted from generation to generation. The epigenetic, the environmental factors play an important role, mainly during the intrauterine period. So the lady has to fit to conceive. Not like that any lady can conceive. Previously, they should prepare themselves to conceive. That's very important. If at all they are obese, they should reduce their weight. And if even the lean, if they are sedentary, they should keep themselves active. See to that their blood sugar and other parameters. If it is all okay, yes, they can conceive. And you heard that GDM is the mother of all non-communicable diseases. So stop celebrating. It's like hitting 2 mangoes in a single shot. If you do what my professor said in the first speech, like if you screen, detect early and catch them, it's like hitting 2 mangoes in a single shot. You can prevent all the non-communicable diseases. Only a healthy mother can produce a healthy child. So stop celebrating pregnancy with so much of sweets and feast like this. This is the thing happening. They think they take care of the mother so much and make them gestational diabetic. And all these mothers, being some professionals, they keep watching some screens and keeping on eating some fast food instead of taking what is made in the house. Because they are educated, they do all this. They are not really educated health-wise. See these women, our mothers and grandmothers, have you seen so much of non-communicable diseases? No, not at all, because they were giving birth to children along with doing all this work. So they didn't have any problem. Of course, now everything has become mechanized. It's washing machine, dishwasher, or a grinder, mixie, and you can cook for a week and keep it inside, take every day and heat it. Like this, everything has become mechanized, and you need not get up and go and put the switch. You can do it everything over remote control. And even farming and watering the farms, you can do it from your house. You need not go to the farm and do that all. What happened to all this? Those days, we all had so much masterful playing games period, and we keep on. Almost every day we did all this, and we all learned either skipping, dancing, and when you come to school, you have to help your parents in the morning, your father as well as your mother doing some houseworks. And if you see children, they used to be very active, running here and there. Now you can see how sluggish they are. So this is the main cause. And we, of course, if we have, for all we have something in those days, it will be the cycle. If somebody comes in cycle, it was a prestigious issue. But now, nothing, no exercise. And we had some extracurricular activities, all females in the house. Even boys used to like putting columns, all this. This is a very good exercise, yogas, these games. Everybody was interested in some game, and in the school, compulsorily they have to be in some games. All those has gone. If you see our temple, it's our olden temples are very big. And we need to, according to the wish, what we want, we need to go around the temple for 2 times or 3 times or 108 times like that. So this itself reduced our diseases. We put up sit-ups, which is called as Suprabhay Yoga, and we do kneeling down. And our gods are not sitting in the plain; they sit at the top of the mountain where we have to climb and go get the blessings. Now we have invented all these rope car, winch, and wait for that for more than 2-3 hours. Then only we climb. Instead, we can climb the temple within a mountain within 30 minutes. And all these extracurricular activities, what happened in the school, and every lady or male or female used to learn all this. What happened to all this? Everything has gone. No extracurricular activities except for screens in front of them. Some sort of screens where they watch all this. If somebody does, everybody will watch that. So even if you're at a place where you have to sit and work, you can do chair yogas. Keep stretching your thing and moving your legs. All that can be done. All these should never be a one-time program, but a regular ongoing, because I have told you today, you may go talk about all this today and you may follow this for a week, but after that you may totally forget. So it should be an ongoing regular process. So avoid lack of exercise, overeating, negative habits, mainly the stress. Exercise, have a balanced diet, do an annual regular checkup, and have some relaxation technique. That's very important, especially for our doctors, to keep ourselves healthy. And this health management is free and enjoyable, whereas disease is costly and painful. So you choose whatever you want. All these diabetics, though they had, it's not a roadblock to their achievement. See, this man is a triathlete champion with long years of diabetes. He is a universe, and this is on Miss America. And this man has lived with diabetes for 70 years. He has lived for diabetes with 85 years. And this man, because of proper lifestyle, he has lived with diabetes for 63 years. And she has lived for 67 years. All these was possible only because of proper lifestyle. You all know Wasim Akram. He is the cricket player who takes 4 or 5 times insulin a day. He is hale and healthy than non-diabetic population because he was following the proper lifestyle. Thank you.
Thank you, madam. That was a most rewarding concept for lifestyle management. Thank you very much, madam. Now, shall we go on to the question and answer session, madam? We are already running late.
Yes.
Yes. If there are any questions, the participants can definitely ask.
First we can.
Yes.
You can unmute yourself and ask, ma'am. Gopalakrishnan, sir. நீங்க எதுக்கு you can unmute sir. If there are any questions, you can ask, sir.
ரைட் இருக்கட்டும், வேற ஒன்றும் ப்ராப்ளம் இல்லை. கொஸ்டின் சொன்னதுல வேற எதுவும் இல்லை, ஆடியன்ஸ்க்கு கேட்டோம்.
Okay. I think one doctor asked a question, which drug to start in a new diabetic patient?
Yes, sir.
Yeah, Balamurugan, I will answer.
Yeah, please, Paneer.
Right, which drug means you have to assess the fasting blood sugar and PP blood sugar, A1C, or they have random blood sugar of 248 or 350. Better to do another blood sugar same day with a couple of meter, or next day fasting PP possible. And type 2 diabetic, non-obese, obese, all those you have to assess. But whatever it is, as Dr. Bhavadharani pointed out, lifestyle modification diet he has to follow. Fasting blood sugar is more than 150, PP is better, small dose of insulin to avoid glucotoxicity. Not willing for insulin, go for metformin 500 milligram BD or metformin plus alpha glucosidase inhibitors 0.2 milligram plus 500 milligram BD. That can be safe. Then repeat the blood sugar after 10 days or after 2 weeks. Then assess accordingly. Then add a further drug. If it is getting controlled, you maintain the control. That way only you have to proceed.
Those who are not listening, please mute your microphones.
Blood sugar is grossly high. Better to educate the patient, motivate the patient towards insulin therapy. Towards insulin therapy more than 350, 400. Better give insulin rather than tablets. Tablets will further worsen, or tablet may not effectively control. They may land up with hyperglycemic coma. So for fresh cases, assess the patient, assess the glycemia. Accordingly, you prescribe oral drugs. If it is gross hyperglycemia, better insulin therapy. Especially if single dose means Glargine you can give 10 or 15 units. That will bring down the blood sugar to a certain extent. Then after 1 week, you repeat the test. Then accordingly titrate the dose. Once you achieve the normal glycemia or near normal glycemia, then you can withdraw insulin, go back to tablet.
When sir said you can add the next drug, please learn what are gliptins, what are SGLT2 inhibitors, what are alpha glucosidase inhibitors. When you are adding the next, please don't add another gliptin or another SGLT2.
Same, yeah.
Alpha glucosidase. Just know all this.
Sir, my question, Dr. Bhavadharani.
Dr. Paneerselvam?
Yes, sir.
Dr. Paneerselvam, I'm Dr. Sundaramurthy, pulmonologist.
Yes, sir. Yes, sir.
Hope you remember. Well done, sir. Well done. Whatever a clarification.
Thank you, sir.
In future, any possibility of oral insulin or stem cell therapy?
Yeah, oral insulin is under trial only, sir. It has not come for clinical use. But oral insulin, it is often getting digested in the intestinal tract, not being properly absorbed. For 10 units of parenteral insulin, we have to give 100 units of oral insulin. Despite 100 units, even though the portal delivery is there, the control is not that much adequate. And the cost of therapy also high. They keep on trying for almost 100 years now. Oral insulin yet to come. Till today, it is not available, sir.
What about stem cell therapy?
Stem cell therapy also on trial only, sir. On trial.
Okay. Thank you,
Sir,
Thank you, sir. Thank you.
Thank you.
Sir, one doctor has asked about what about bromocriptine in diabetes mellitus and when to introduce and whom to start.
Bromocriptine got introduced 10 years before. It was supposed to clear the insulin resistance, but that drug was not that much promising. It was not effectively controlling diabetes. Now it is slowly weaned off. We are not using bromocriptine now. We have better molecules now. So bromocriptine
Actually, they say we have dopamine deficiency in the morning. So in the pathophysiology, we thought if we introduce that, it will help. But practically, when we tried, it's not giving that much
effect.
Question to Dr. Paneerselvam, sir. Sir, the tablet Limipray 2 mg BD, you said it's not advisable. It's very surprising, sir. And
I will complete now. Many doctors are still till today not understand that. Only I have shown many slides on sulfonylurea. See, sulfonylurea after 96, there is no further modification of sulfonylurea. 1956, carbutide got introduced. then tolbutamide, chlorpropamide, glypizide, glibenclamide, glycoside, then glimepiride. For the past years, we had 6 or 7 molecules. Now, for the past 25 years, no further modification of sulfonylurea because the entire globe is under the impression.
Madam Premalatha, madam.
Yes.
Mute your microphone, mute your microphone.
Okay.
Let us not spoil the remaining beta cell because it persistently stimulates the beta cell, releases the insulin, degranulates the beta cells, causes apoptosis, beta cell failure, sometimes beta cell death, hypoglycemia, glycemic variability, cardiovascular safety is not there. Because of this only, sulfonylurea is being discouraged constantly. So that we request all the practitioners, if already they are on sulfonylurea, let them continue. If we add gliptin or gliflozins, we have to reduce the sulfonylurea dose rather than stopping the gliptin or gliflozins, or use minimum amount of sulfonylurea. If you use minimum amount of sulfonylurea, the remaining beta cells are preserved or saved. If you go for higher amount of sulfonylurea, we are spoiling the remaining beta cells, or we are pushing the patient towards hypoglycemia.
And other thing, if you see, the sulfonylureas are not acting in the maximal dose, there is no use in further increasing the dose.
Then another aspect also, once they land up with the beta cell failure, no point in giving 3 milligram BD. See, type 2 diabetes after 15-20 days or duration, they go for beta cell failure, they behave like type 1 diabetes. If such is the situation, if you give sulfonylurea 3 milligram BD, it is not at all going to be useful also.
Sir, Balamurugan sir,
Yes.
Balamurugan sir, one has asked a question, what makes us to decide insulin 50-50 or 30-70 or 70-30?
Yeah, basically, basically when we look at the fasting plasma glucose and postprandial plasma glucose, when the difference between the fasting and postprandial is more than 100, 150, we tend to choose a 50-50 insulin. When you find the difference between the fasting and postprandial is less than 100, you can go for the 30-70 or 70-30 insulin, number one. And there's also other question, which is the drug safe in use in CKD patients with chronic kidney disease. I will take up this question and answer also. Okay. Usually the linagliptin, among the gliptin, linagliptin is one of the thing, one of the drugs which is very safe to be used. We have got data, and other gliptins have to be modified and used. In fact, we have data from the SGLT2 groups. Most of them are useful in preventing to some extent postponing the CKD also. And we have data from the Credence and Credence trial also to support that. And even they have tried to use SGLT2 up to GFR 20 to 30. Okay, so these drugs and short-acting insulins. Once upon a time, we used to use glipizide, which is short-acting sulfonylurea, but no more we use now.
Insulin 30-70, 50-50 for what group of patient? The main question is for that purpose. And 70-30 also they have asked it. 70-30 also they have asked.
Yeah, we have only
70-30 here, not available.
Not available here. We have only 30-70 here.
Yeah,
Okay.
30-70 and 50-50.
And also 25-75 by Aventis.
That is
We have
almost
only
same.
this.
Almost same. So PP blood sugar is not getting controlled by 30-70. You can go for 50-50. You can go for 50-50. Despite that, some of them are not getting controlled. You can add additional dose of Apidra or Nova Rapid if it is not getting controlled.
Yeah, okay. And the same 30-70 is called as 70-30 in US. I mean, 30-70 combination, they call
yes,
it
they call it like
both
that. And this 30-50, what we give is the bolus insulin, which is short-acting and controls the postprandial. So if you are not getting control with 30, we increase it to 50. The short-acting part is the one which is before. That is the one which is controlling the postprandial. If you are not satisfied, not getting adequate control with 30-70, go for 50-50. We are increasing the bolus.
There's one more question, sir. At 8 weeks of pregnancy, there will be most of the patients will have hyperemesis. So, will that rule of 110 be applicable for this metformin therapy?
110 is postprandial. 110 is postprandial.
No, the practical problem is hyperemesis. So,
let her have hyperemesis. How much ever she has taken, you do a random blood sugar or in the morning or afternoon or night, any time. They should not cross 110 because 110 is the fetal renal threshold. The fetus cannot tolerate beyond 110. Once it reaches the fetus, it will start functioning, fetal pancreas. Once it is triggered to function, the action will not stop. Initially, it will be secreted to control the mother's blood sugar, but later what will happen? It will steal the blood sugar from the mother. So if you are delaying the diagnosis, what will happen? The mother's blood sugar may look very normal, but hyperinsulinemia and all other problems in the fetus, in the baby, as well as in the future of the baby.
Yeah, Dr. Bavadarani and Sendil, with your permission, Tanay, I'm going for another IMA meeting. To IMA, Indian Medical
Yes,
Association
yes,
meeting.
thank you, Dr.
Yes, sir.
Balamurugan.
Yes, sir. We are very aware, sir. It's 7 o'clock here. Thank you, sir. Thank you, sir. Thank you, sir.
Thank you. Thank you, Paneer.
Thank you,
Bye-bye.
Balamurugan.
Thank you.
Good, good to see you all.
Sir, one more interesting, sir, one more interesting question I see,
Dr.
sir.
Jeevarashman, sir, I have a question, sir.
Yeah, please, sir.
Yes,
Sir.
Dr. Anand.
Sir, is there
Madam,
any role of empirical treatment of statins or blood thinners in diabetes?
Well, we couldn't hear you well, doctor. Empirical treatment of?
Sir, empirical treatment of statins and blood thinners, sir. If a patient has more than
No, somebody should mute. It is interfering.
Yeah, somebody is disturbing. Others who are listening, please don't disturb.
Right. Dr. Statin, empirical treatment. Hello.
Doctor, whoever you have asked, please remember the diabetes and atherosclerosis, they arise together. They start together. Diabetes is a cardiac equivalent. So if they have, if you want to start, you can start statins in diabetics.
And any other question?
Sir, good evening, sir. Can you hear me?
Yes.
Good evening.
Dr. Pannisalam, can you hear me?
Yeah, I could able to hear you, sir.
It's a nice meeting by you, Bavadarani and Dr. Balamurugan. I'm Dr. Rangarajan from Coimbatore.
Oh, yes, sir. Please, sir.
Sir, one thing I want to add is, see, whatever food we are eating, let's say cookies, it contains sugar, maida, and vanaspati, which are very deleterious to the patient in producing obesity as well as diabetes.
Yes.
Maida is manufactured by using all kinds of chemicals, which is causing beta cell toxic. And
Yes,
that is
sir.
the reason why we get a lot of diabetes.
Yes,
So
sir.
that is a very one point which you have to make sure. And one more thing I want to just share with you people, when we attend any seminars or meetings or conferences, what
Yes,
we
sir.
speak at the podium, we don't practice outside in the dining hall.
In the same area, in the same hall.
No. So that is not a good thing. And one more thing which I would like to share is the reason for the rise in diabetes is because of the use of lot of pesticides in all fields, including the fodder which the cow eats. It contains pesticides, and that pesticides is consumed by the people in nanograms, which is toxic to the beta cells.
Beta cells. Mother's
So-
milk as well as cow's milk, both are having pesticide.
Yes, sir.
Many causes, like how they are in the pathogenesis, but the causative organs, it's plenty.
What you are saying is correct, sir.
So prevention is better than cure, sir. What I do in my practice, when a patient comes, they come along with some of the relatives. I catch them in that stage. Your BMI is high. You have got acanthosis nigricans. Your waist is high. I catch them and I just give them a small advice.
Yes, sir.
See, you go to any doctor of your choice, but please check all the parameters.
Correct,
Number
sir. So for that purpose only, as you said, sir, we are sensitizing the schools and colleges through Blue Circle Club. So all over in Tamil Nadu, we are sensitizing all the children in the colleges as well as school, catch them young before they develop diabetes, obesity, hyperlipidemia, hypertension. Let them know something about it and let them know the normal level. Let them translate this normal to the parents or grandparents. See to that everybody is getting prevention knowledge or early detection, persistent good control, by which at least the complications can be avoided.
See, even the obese, you can make them metabolically healthy by following the lifestyle what we advised.
Yes. If you clear the insulin resistance, they are becoming free. Otherwise, pre-diabetes, that is called pre-diabetes. That is, obesity is called pre-diabetes.
it is very important. We should try to go in the primordial prevention and
Yes, sir.
educate the mothers, grandmothers, grandfathers, uncles, aunties, which they are dumping all kinds of the unwanted
Adalla-
foodstuff to children.
Yeah, at the age of 86, that Shesha is keep on shouting all over world, not only in India.
Sir, it is now not called diabetes. Diabetes said to the core level. And
Yes,
as
sir.
rightly said by our professor, it is not an endemic or an epidemic. It is pandemic.
Pandemic.
So
Thank you, sir. Thank you
I
for
said, I
everything.
wish you continue such programs, sir. I'll be very happy and try
Thank
to
you,
interact
sir.
with you people,
Thank
sir.
you, sir.
Thank you.
you,
Thank
sir.
you very much, sir. Thank you.
Sir, it is a one more question. Audible?
Yes, sir.
Yes, sir.
Yeah,
you're
yes, sir.
audible.
Dr. Gopalakrishnan, the CGP team, IMA.
Yes,
Sir,
sir.
regarding the newer insulin, which
Yes,
is
sir.
the cost-wise, which insulin you are suggesting to the general practitioners?
The
Cost-wise,
cost-wise, if you see, analogs are very costly. The conventional insulins are cheap compared to that. Only thing, depending on the patient, you have to advise if they are taking conventional, it has to be taken 20 to 30 minutes before food. It's a must. Whereas if you take the analogs, many things, short-acting, all 5 minutes, 10 minutes. Whereas the analog short-acting, they have a window period. They can take just before, during taking food, or even after food. Our patients, when they get admitted, we don't know if they may get admitted for vomiting. They may be very sick, fever. We don't know whether they are going to take food or not. They may say they take. So you see to that, then you can give. That is the advantage of analog. It has got a broad window period. Whereas the conventional insulin, the cheaper, like our Actrapid, Mixtard, and other things, which cost only 175 rupees, whereas these analogs, they cost 600, 700, 800, and above 1,000. All these are very safe, but costly. And window period, safety is there.
Control is there for both. Only thing for human insulin, you have to take 10 to 20 minutes or 15 minutes before food. Analog can be taken just before food or even after food also.
so among the analog, the cheaper one, cost-effective is Vasolag.
They have almost same only, all three.
So no
brands
cheaper analogs. No cheaper analogs.
all
cheaper
three brands
analog.
are almost same.
So-
Almost same.
They may
Almost
say
same.
biosimilar, but
Yeah,
even that cost like the original analog.
Original.
Analog,
Price is
right.
similar. Only it is biosimilar, but price is similar.
Price is same only.
Thank you, sir.
Is there any other questions?
Sir, Glargine is costing 630 rupees only, sir. Even the innovator molecule is costing only 60-30. And although biosim is costing 60 as far as Glargine is concerned, which has come under price control.
Yes, sir. 600.
But
Now,
600
they
is
have
costlier compared to NPH. NPH costs 175, but it has a unwanted peak somewhere. Unknown unwanted peak, which can cause hypoglycemia. Whereas you don't get that peak with Glargine. Even
Madam,
100, it cannot control throughout the 24 hours. So you have to go for 2GO, the Glargine 300. Otherwise, the Tresiba, Deglutec, which can act up to 36 to 42 hours. The advantage of Deglutec is if you're taking today at 8 in the morning, tomorrow you can take at any time, even 8 in the night. It is not on the same time of the day. It works up to 42 hours. Sometimes you can skip a day in between, which covers. In a week, instead of taking 7 days, you can take even 5 days a week. But you have to carefully calculate that it should come within this 36 to 42 hours.
Glargine is also available in vial, madam. Vial. Also available. Glargine
Yes,
in
it is
vial.
available in vial as well as pen fill. Both are available.
Vial is somewhat cost effective. Vials.
Vials, little cost effective. Pens, yes, pens are, of course, if you say the representatives, you can get the pen free. If they get off their own, the pen costs 1,200. No, it's given free for all of us. If they get from us, we'll give the pen free along with the pen fills.
So there is a question, madam. One doctor has asked, can you suggest an insulin regimen to be followed at the rural PHC level for gestational diabetes mellitus?
In the rural PHC, you can just start with whatever insulin you have. I think you have the mixtards. If it is, the blood sugar is very low, it's not that high, then you can start with mixtard.
Excuse me, ma'am.
postprandial both
are-
are high. Remember, they'll require
No,
3.
no, there is the interruption. Somebody is asking intervening.
Excuse me, ma'am. We are
Mira.
supplied with only basal insulin and lenti-insulin, not the
Okay.
mixtures, ma'am.
Basal lenti not that useful in pregnancy because only postprandial is the problem, mostly in GDM or pre-GDM. This is the difficult one to control. This is a very precious short-term period which is going to give long-term benefits in the newborn. You have to use short-term. But what you're saying is all are basal. Basal will not help in controlling the postprandial. They need 2 to 3 injections of bolus, that is short-acting insulin. Whatever regular insulin you are having has to be given for all 3 meals if the blood sugar is high. And this basal, what is available, what you're saying, can be given either in the night alone or in the morning and night according to the blood sugar. There is no standard protocol. It differs from every patient to patient.
Otherwise, to start with, if you have mixture to start with 5 units, you can give. Then monitor the blood sugar. If post dinner is not getting control, you can add another dose of 5 units in the night. Then by monitoring the blood sugar, you have to titrate the dose. If you have actrapid alone or insulatard alone in PSC or in your center, to start with actrapid 2 units, insulatard 3 units morning, then monitor, then add actrapid 2 and insulatard 3 in the night. Likewise, we have to titrate the dose, doctor. Like ampicillin.
Nagapushpam, you said what insulins are available?
Basal insulin and lenti-insulin only available, ma'am.
Doctor, basal and
It
lenti
is
both
in
are same
PHC.
only.
Both
No,
are
no.
same.
What you can
Both
do,
are
you can
same.
refer to the GH and ask them to get on plain
No,
and
no.
come.
What she is telling is actrapid as well as insulatard, I think. Basal and
no.
lenti both are intermediate acting only. Both are.
Okay, sir.
We will not supply.
So
Nowadays, lenti not available, sir. Not available in PSC.
Yes,
Lenti.
lenti is totally stopped.
They
Yes.
stopped it. Yes, sir.
So she is conveying only actrapid and insulatard only, she says.
Actrapid and then installed. Both are available in PSC.
Oh, good.
Actrapid is available means you have to use more of
Sir,
actrapid.
sir, excuse me. Sir, in GDM patient, can we add metformin along with insulin, sir?
No, then you have not listened to Dr. Seshaya lecture.
You can. If
No,
the
only
patient
after
is not...
only after 12 weeks.
No. That only has changed. You can start using from conception to delivery. You have seen plenty of the physicians using metformin before, during conception, and after conception, throughout pregnancy. We have adequate
Example
evidence.
is PCOS. Before
Yes.
they conceive for PCO, they give. They continue throughout the pregnancy. No harm is happening.
See, if the patient is not willing for insulin, you can start with metformin. Or else, if the patient is going for very high doses of insulin also, you can put a metformin along with insulin. Insulin is the best, but still, it may not be available or the patient may not be accepting. In those cases, you start with metformin. It's not getting control. You have to add insulin. If you have started already on insulin, insulin dose requirement is very high. You have to add metformin.
Okay.
Madam,
Thank you,
I
madam.
think it is an exhaustive discussion, madam. I think they have 2 or 3 lectures at AMS at Coimbatore. So on a lighter note, I'll stop with only one question, madam. One
Let them
doctor has
all
told,
join the course and have more details.
yes, ma'am. One doctor has given on a lighter note. Hereafter, we'll have to attend the CGP CME by standing only, so not to sit more than 2 hours. So yes, given on a lighter note, I think we'll stop with this, ma'am. And I would request our CGP Joint Secretary, Dr. Suresh Kumar, to give the vote of thanks, ma'am.
Thank you, Dr. Anand. Thank you. Thank you. You have
Thank you, sir. Thank you very much, sir.
Thank you, sir. Thank you very much.
Almost 700 people attended.
Dr. Suresh.
Thank you, Dr. Gopal.
Dr. Suresh? Yes. Please propose the vote of thanks, sir. You are not audible, Doctor, sir.
There's disturbance.
There is disturbance, some fan or something.
No, his mic is not functioning.
Sir, your mic is not functioning. Suresh, sir?
Sir, am I audible now?
Now
Yes.
you are
Yes,
audible, sir.
yes.
Okay. First, my sincere thanks to our president, Dr. Abul Hassan sir, and immediate past president, Dr. Sendil Pari sir, and president elected Dr. Sridhar sir for facilitating this wonderful function. And my sincere thanks to our state secretary, Dr. S. Karthik Prabhu sir, for initiating the wonderful CGP course, and my thanks to Dr. V. Shesaya sir for giving his wonderful lecture regarding the primordial prevention of diabetes, and the excellent his talk states about this preventing aspect starts from the womb of the mother. It's maybe it's new to most of the general practitioners. And my thanks to Dr. Balamurugan sir for explaining about the newer insulins. And he told us some of the crazy things in the 20 years back comes to practicing now. It gives the new thought about to the new, our young generation doctors. And our thanks to Dr. Paneerselvam sir giving the explained extraordinary topic about the pathophysiology of the diabetes mellitus, and telling about the how to prevent the beta cells of our pancreas. Actually, we didn't know about how to prevent the beta cells. It's wonderful starting, and thanks to Dr. Bavadarani madam for changing for telling about the lifestyle modification. And she told there is no good or bad diet. It is about our usage, the proper diet, and right quantity and quality. I think our doctors will join in this course, and will know more about the diabetes. Thank you all. Thank you all for giving this opportunity to interacting with you. Thank you.
Thank you. Thank you so much. Thank you. Dr.
Thank you,
Bhavadharani.
Dr. Anand and
Thank you,
Dr.
Bhavadharani madam.
Sendil,
Thank you,
for
Paneerselvam
arranging
sir.
this wonderful meet.
Yes.
Dr.
meeting.
Anand
Yes,
and Dr.
About
Sendil.
750 people attended. I think more than
Yes,
750.
average was 730, sir. It's very informative, sir. We'll try to
Yeah.
maintain it, sir. Thank you, sir. Thank you, madam.
Thank you. All the
Thank you,
best.
Suresh, sir.
Thank
Thank
you
you, sir.
all.
Thank you, sir. Thank you very much.
Thank you, Anand.
Thank you,
Thank you.
sir. Thank you.
Thank you, madam. Bhavadharani madam. Tamu
Thank
speaking.
you. Thank you, sir.
Yes. Thank you.
Yeah. Yeah.
அப்படின்னா ஒரு மனுஷன் இந்த உலகத்துல வாழ்ந்த காலங்கள் எவ்வளவு பெரியதா இருக்கு. எனக்கு இன்னைக்கு கூட எழுதியில நைட்டெல்லாம் ஒரு நாள் சாப்பிட்டு போடப்பட்டு குழந்தை முடியல. எந்த வயசுல இவ்வளவு லேசான வேலையை இவ்வளவு கைகளும் நீ சொல்றாங்க. அவங்க போன வருஷம் அதே பயிற்சிக்கிட்டு வந்தப்ப இந்த ஞாபகம் இப்ப நான் நேரத்துல அந்த கட்டை பேசிட்டு வரேன் எனக்கு ஞாபகம் வருது. போன வருஷம் பஸ்ல ஏறினாம அவங்களுக்கு தூக்கி விட நான் இருந்தேன். அவங்களை ஏற்றி விட்டுட்டு அவங்க கட்ட பையன் நான் தான் நினைப்பேன் நம்மளுக்கு ஆள் இல்லைன்னு. ஆண்டவர் அருமையா இப்போ ஒரு டீச்சரை துணை கொடுத்துட்டாங்க. நானும் மங்களமும் அநேக நேரம் உள்ள 2 நாள் அவங்க இறந்தா பிறகு 2 பேரும் உள்ளே உட்கார முடியல, பிள்ளைகளே பார்க்க முடியல. 2 பேர் அழுத தவிர வேற ஒண்ணுமே செய்யல. மங்களமெல்லாம் கதறி பிள்ளை பயமா சின்ன பிள்ளைங்க இருக்கு பதறி இருங்க அப்படின்னு ரொம்ப அழுதுட்டாப்ல அப்படின்னு. ஆனாலும் ஆண்டவர் அவங்க ஒவ்வொரு நாளும் அவங்க கருத்து கற்றுக்கொண்ட ஒரே ஒரு நல்ல காரியம் எல்லாருமே கத்துக்கோங்க, ரொம்ப பொறுமை. அண்ணன் வெளியே போயிட்டு வந்து அதான் இதான் இப்படி செய்யல அது செய்யல ரசிச்சுட்டே இருப்பாங்க. எப்படி இப்படி முடியுது? ஒத்த வார்த்தை சொன்னோட நம்மளுக்கு புலம்புலன்னு கண்ணீர் வருது, கோவம் வருது. அவர் பேசுறதை விட 2 வார்த்தை பேசினாதான் நம்மளுக்கு மனசாருது அப்படியெல்லாம் நான் நினைப்பேன். ஒரு வார்த்தை பதில் பேச மாட்டாங்க. சரி வாங்க சாப்பிடுவாங்க, 3 மணி ஆயிரும் சாப்பிடவே மாட்டாங்க. அண்ணன் எப்ப வருவாருன்னு பாத்துக்கிட்டே இருப்பாங்க. இது ஏப்ப சாப்பிடுங்கம்மா, அண்ணன் வந்து அது உங்களை நீங்க சாப்பிடுறதுன்னு அடிக்க ஏன் சாப்பிட்டேன்னு அடிக்க வராது. சாப்பிடுங்கம்மா, நாங்க சாப்பிடுறது அண்ணன் வந்தாக்கிறதா நான் சாப்பிடுவேன் பழகி போச்சு அப்படின்னு. இப்படி ஒரு மனுஷி இவ்வளவு குறுகிய காலத்துல வாழ்ந்து எல்லாரும் மனசுலயும் அவங்க இடம் பிடிச்சு போயிருக்காங்க. அண்ணனுக்கு வந்து ஆண்டவர் வந்து நல்ல நீண்ட ஆயுசையும் இந்த ஊழியத்துல பொறுமையை கொடுத்து அவர் நல்ல முறையில இன்னும் அது அநேக காலங்கள் உங்களோடு கூட இருந்து அவர் ஊழியம் செய்யணும். அவங்க விட்டுட்டு போன பணியை நாங்க தொடர்ந்து செய்வோம். அதுக்காக ஆண்டவர் தேவையான பலனை தருவார்.
சகல ஆறுதலின் தேவனுக்கு சொல்கிறோம். அருமையான இந்த நாளிலே காலையிலே ஒரு முறையாக ஒரு தருணம். ஆலய காரியம் 5 நேரத்துல வேலை பார்த்தாங்க. சாத்தூர்ல இருந்தாங்க. 6 நாள் வேலை செய்வாங்க. 7வது நாள் ஒரு நல்லது கெட்டதுனாலும் அம்பிகாரம் போனோம். 7வது நாள் மறுபடியும் ஆராதனைக்கு அண்ணனோட சேர்ந்து ஆலய காரியங்களில அவ்வளவு கவனமா இருந்தாங்க. 2வது ஆகார காரியம். வீட்டுல வந்தாலும் இங்கே சாத்தூர்ல வீட்டுல சமைச்சு, அங்க அம்பிகாரத்துல ஊழியக்காரங்க வந்தாங்க அவங்கேயும் சமைச்சு, எங்க ஊர் மேல போகுது அவங்க அம்மா அங்க இருப்பாங்க. ஒரு சின்ன டப்பாயில ஒரு ரசத்தோட எடுத்து அதுக்கே கொடுத்து ஆகார விஷயத்திலையும் துடிப்பா இருப்பாங்க. 3வது ஆண்டவருடைய ஊழியம். அக்காவுக்கு சுகர் தான். ஆனா அண்ணன் கூட எல்லா ஊழியத்துக்கும் கூடவே போவான். இன்னைக்கு ஒருவேளை இங்க இருக்கக்கூடிய சகோதரிகள் எப்படி அப்படின்னு சொல்லி நீங்கதான் யோசிக்கணும். அவங்க எல்லாருக்கும் பலவீனம் இருக்கு இல்லைங்க. 6 நாள் 5 நாள் ஸ்கூல் முடிஞ்சு 6வது நாள் அன்பு நேரத்துல ஒரு விஷயம்னாலும் போவாங்க. 7வது நாள் ஆண்டவருடைய ஊழியத்துக்கும் போவாங்க. அதனால ஆலய காரியத்திலையும் ஆகார விஷயத்திலையும் ஆண்டவருடைய ஊழிய விஷயத்திலையும் நமக்கு ஒரு முன்மாதிரியை விட்டு வச்சுட்டு இருக்காங்க. நாமும் அப்படிப்பட்ட ஒரு நல்ல பண்புகளை உடையவர்களாக இருக்கிறோம். இந்த விஷயத்துல இது எல்லாமே சட்டனை இழந்து இருக்கக்கூடிய அண்ணனுக்கு, பிள்ளைகளுக்கு, வந்திருக்கக்கூடிய மருமக்கமார்களுக்கு, உறவினர்கள் எல்லாருக்கும் சகல ஆறுதலின் தேவன் ஆறுதலை தர வேண்டும் என்று சொல்லி நாம் எல்லாரும் தொடர்ந்து நினைச்சிருக்கோம்.
இப்போதும் நாம் கேட்கிற செய்தியை தேவன் ஆசிரியர் இருக்கிற டேவிட் ஹென்றி ஐயா அவர்கள் ஜெபம். எங்களை கிருபையா நேசிக்கிற நல்ல தகப்பனே, அருமையான மாலை வேலைக்காக மீண்டும் நமக்கு நன்றி சொல்லுகிறோம் ஆண்டவரே. இந்த வேளையிலோட அருமையான இந்த இடத்துல நாங்கள் என்ன நோக்கத்திற்காக கூடியிருக்கோம் என்பதை கர்த்தர் அறிந்து அனைவருடைய சாட்சிகளை கத்தர் கேட்டு நாங்களும் கேட்க மாட்டேங்கிறேன். அருமையான சகோதரருடைய வாழ்ந்த நாட்களிலே அவருடைய ஆவிக்குரிய வாழ்க்கை, உலக வாழ்க்கை, அவருடைய குடும்ப வாழ்க்கை, இன்னும் பல்வேறுபட்ட செய்திகள் நாங்கள் ஆண்டவரை இந்த வேலைகளுடைய சாட்சியின் மூலமாக கேட்டிருந்த ஆண்டவரை. அருமையான அந்த குடும்பத்தின் பிள்ளைகளை கூட கத்திரிப்படியாய் ஊழியத்தின் பாதையிலும் ஆண்டவரை உலகப்புறமான காரியத்திலும் இந்த நாள் வரை கிருபையாய் பாதுகாப்பாய் வழிநடத்தி வந்த நினைத்து நமக்கு நன்றி சொல்கிறோம். இந்த நாளிலே நாங்கள் திருச்சிபையாக, உறவினர்களாக, இனஜன பந்துக்களாக, நண்பர்களாக, உடன்பிறப்புகளாக கூடி வந்து நம்முடைய சன்னிதானத்துல நாங்கள் இந்த கூடுதலை பங்கேற்க முடியாத கிருபையை கற்றுக் கொடுத்து நன்றி சொல்கிறோம் ஆண்டவரே. பாடல் வேலையும் செய்தி வேலையும் கற்ற கிருபையாக நீ ஏற்று அங்கீகரித்துக்க நன்றி சொல்கிறோம். தொடர்ந்து செய்தி வேலைக்காக சமூகத்தில் வேண்டுகிறோம். இந்த வேதத்தின் வார்த்தைகளானது இந்த அருமையான குடும்பத்தின் பிள்ளைகளுக்கும் வந்திருக்கிற எங்க பிள்ளைகளுக்கும் எங்களுக்கு கூட ஆவிக்குரிய வாழ்க்கையில நல்ல ஒரு சிறந்த புதனையாக இருக்க, நல்ல ஒரு ஆரோக்கியமான சத்தியமாக எங்களுக்கு கேட்கப்பட தேவன் கிருபை அளிக்க வேண்டும் என்று சொந்து வேண்டுகிறோம். தொடர்ந்து இந்த குடும்பத்தின் பிள்ளைகளை வந்திருக்கிற கிருபையை வெளியிடத்துங்க. உடைய கிருபை பிரசனம் இந்த இடத்துல நிறைந்திருப்பதற்காக நன்றி சொல்கிறோம் ஆண்டவரே. இந்த வார்த்தை கூட எங்களை ஆவிக்குரிய வாழ்க்கையில தேற்றும்படியாக உதவி செய்ய மீட்பிரசின் சிவங்களும் ஜீவனுள்ள பிதாவாகிய தேவனே ஆமென்.
இப்போதும் போதகர் தான் சுந்தரசிங்க அவர்கள் ஒரு செய்தி கொண்டுள்ளார்கள்.
கர்த்தருடைய பரிசுத்த நாமத்துக்கு ஸ்தோத்திரம். அவர்களை சேம்பாமணி, மதுரை சேம்பாமணி திருமணம் நடைபெற்றது எனக்கு தெரியும். சதீஷ்செல்லன் இளவரசியுடைய திருமணத்துக்கு நாங்கள் போயிருக்கிறோம். அது மட்டுமே ஆசீர்வாதம் அவர்கள் பயிற்சி செக்கினேன். அம்மா அவர்கள் எங்களை அதிகமாக நேசிக்கிற அன்பின் தகப்பனாக இருந்தாங்க. எல்லாரும் சிவராஜிலிருந்து நடந்து அலையாமல் அதனால 32 ஆண்டுகளுக்கு முன்பே எனக்கு அந்த குடும்பத்தோடு தொடர்பு அதிகமாக நேசிக்கிற ஒரு பணி நிறைவு ஸ்தோத்திரத்தை கொடுக்கக்கூடிய நினைத்தார்கள். நான் சிறப்பு நன்மையை பகிர்ந்து கொண்டேன். நைகம் போன்ற இதெல்லாம் சாட்சி சொல்லியிருக்கேன். பாரமான யாவற்றில் நம்ம நெருக்கிற சாபத்தில் தள்ளிவிட்டு விசுவாசத்தை உத்தரவு முடிக்கிற மாதிரி நமக்கு தேவத்தை பொறுமையோடு ஓடக்கூடிய ஏழை 12 அனைத்து சாட்சிகளை குறித்து சௌரி குறித்து இளவரசியை குறித்து நாம் கேட்டோம். ஒரு நற்சாட்சி உள்ளவராக இருந்தார்கள். இன்றைக்கு வராண்டு நிறைவு பெற்றிருக்கிறது. தேவைய ராட்சியத்துக்கு போகுது. நம்ம ஒரு நாள் ஆண்டோட ராட்சியத்துக்கு போகுது. ஒரே ஒரு வாழ்க்கை சீக்கிரமாய் கடந்து போகிறது. ஆண்டவருக்காக எதை செய்கிறோமோ அதுதான் கடைசி நிலைத்த சொல்லி தற்செய்கிறது. ஆகவே நமக்கு ஒரு நம்பிக்கை ஆண்டு நித்திய நம்பிக்கை, ஜீவன நம்பிக்கை, மகிமையான நம்பிக்கை. இந்த நம்பிக்கையின் அடிப்படையே நம்மளை மீண்டும் ஒரு நாளே சௌரிய இளவரசியை பார்ப்போம் என்ற நம்பிக்கை நமக்கு. நாம் யாரும் சாதாரண பெற்றோர் கிடையாது. வேதம் நித்திரை என்றுதான் சொல்லப்படும். மரணத்தை வேதம் நித்திரை சொல்றது. இறைவனை படிக்கிறோம், காலையில எழுந்து. ஆகவே நித்திரை என்றுதான் வேதம் சொல்றது மரணத்தை. ஆகவே அவருடைய எல்லா பிரயாசங்களை விட்டு அவர் நினைப்பார்கள். அப்படிதான் வெளிப்படுத்தின விசேஷம் 14:13 கர்த்தத்தில் வைத்த முதல் பாக்கியம் உண்டு. அவர்கள் தங்கள் எல்லா பிரயாசத்தை விட்டு வேலைக்கு வருவார்கள். அவருடைய பிரயாசம் இந்த உலகத்தில் எவ்வளவு பிரயாசம் பண்ணார்கள். புலவர் ஜோசப் அவர்களுக்கும் சரவணை டீச்சருக்கும் அருமை மகளாக பிறந்தார்கள். அவர் அடிக்கடி அவங்க வீட்டுக்கு போவார். அவர் பிரசிடண்டா இருந்த காலத்திலே நான் அடிக்கடி வீட்டுக்கு போவேன். அன்போடு நேசிப்பாங்க. அருமையான அம்மா சரவணை டீச்சர் புலவர் ஜோசப் அவர்கள் மறக்க முடியாது. ஆனாலும் நமக்கு ஒரு நம்பிக்கை ஆண்டோட கிடைக்கிறது ஆச்சரியமானது. அந்த நம்பிக்கை என்னவென்றால் உங்கள் இருக்கையும் கலங்காது இருக்கிறாங்க. உங்கள் இருக்கையும் கலங்காது இருக்கிறார்கள். விசுவாசமா இருங்கள். என்னிடத்தில் விசுவாசமா இருங்கள். என் பிதாவின் வீட்டில் அநேக வாசஸ்தலம் உண்டு. அப்படி இல்லாம நான் உங்களுக்கு சொல்லியிருக்கேன். நான் போய் உங்களுக்கு ஒரு சிலத்தை அழைத்தபடி எனக்கு நான் இருக்கிற இடத்தில் நீங்கள் இருக்கும்படி மறுபடியும் உங்களை வந்து என்னிடத்தில் சேர்த்துக் கொள்ளும். ஆண்டவர் அநேக மேன்சனை கட்டி வச்சிருக்காரு. சிவகாசியில நாடர் மேன்சன் வச்சிருக்காங்க. அது லாட்ஜி. நிறைய இடத்துல எங்க மெட்ராஸ்ல இருக்குது நாடர் மேன்சன். அது லாட்ஜி. நமக்கு பரலோகத்திலே அவர் சொந்த கையினாலே கட்டி அழகான வீட்டை வச்சிருக்கு. அதான் மேன்சன், நாட் லாட்ஜி. அங்கே அழகு இல்லை, கண்ணீர் இல்லை, கவலை இல்லை, துன்பம் இல்லை. அப்படிதான் வெளிப்படுத்த விசேஷம் 7ஆம் அதிகாரத்தை சொல்லியிருக்குது. அந்த பரலோகத்தை குறித்து சிறப்பாக வெளிப்படுத்த விசேஷம் 21ஆம் அதிகாரம் 22ஆம் அதிகாரத்தை முதல் 5 வசனங்களை வாசிக்கிறாங்க. இவ்வளவு அழகான பரலோகத்துக்கு தான் போயிருக்காங்க சிஸ்டர் இளவரசி அவர்கள். நம்ம ஒரு நாள்ல போவோம். நான் ஏறத்தாழ 30 வருடங்களாக 32 வருடங்களாக இருக்கிறேன். நிறைய பேர் நான் நடக்கும் பண்ணி என்னையும் ஒரு நாள் ஒரு சொல்லுவாங்க. அதுதான் உண்மை. அப்படிதானே? ஆனாலும் உலகத்திலே சாதாரண 54 வயது வரைக்கும் அவர்கள் இந்த உலகத்தில் வாழ்ந்து அந்த பெற்றெடுத்து வளர்த்து நாளைக்கு நல்ல உயரிய நிலைமையை கொண்டிருக்கிறார். சகோதரி இளவரசி ஜெரால்டு தேவதாஸ் சத்தீஸ்வரன் ஒரு சடங்கு வீட்டு 3 பேரும் உட்கார்ந்து சாப்பிடும்போது சொன்ன சிஸ்டர் ஒரு நாளைக்கு டீச்சர் சொல்லமே நான் பார்க்கிறேன். அதெல்லாம் வாங்கி எங்க வீட்டுக்கு வாங்கி வரவே இல்லை எங்க வீட்டுக்கு வர மாட்டேன் அப்படின்னு கேட்பாங்க. ஒரு அன்பான சகோதரி பிரியமானவர்கள். அங்கே 2 குழந்தையர் 5ஆம் அதிகாரம் 1 முதல் 4 வசனங்களை பார்க்கும் பொழுது பூமிக்குரிய கூடாரமாக நம்ம வீடு அணிந்து போனாலும் தேவனால் கட்டப்பட்ட கைவீடுகளால் நித்திய வீடு பரலோகத்திலே உண்டு என்று அறிந்திருக்கிறோம். நித்திய வீடு எத்தனை பரலோகத்திலே ஒரு நித்திய வீட்டை ஆண்டு வைத்திருக்கிறார். அது என்ன செய்யக்கூடாது, மறக்கக்கூடாது. ஆமா, ஒரு வீடு பிரதேசத்துக்கு போயிருந்தோம். நானே வைத்து பார்ப்பாங்க. அப்போ ஜெரால்டு கார் ஓடிட்டு சத்தீஸ்ல ரோசினி சாலமன் வீட்டுக்கு அங்கே சிவகாசில. அப்போ தாராளமா வாங்க, உங்களுக்கு வேண்டாம், வாங்க பாஸ்டர். கொண்டாந்து பஸ் ஸ்டாண்ட்ல எங்க நினைச்சிட்டாங்க. இங்க ட்ராப் பண்ணாங்க. ஜெரால்டு ட்ராப் பண்ணிட்டு மணி வந்தாங்க வீட்டுக்கு ஸ்கிரீன்ல வாங்கன்னு சொல்லி. எது சொல்றேன்னா அந்த அளவுக்கு அன்பான ஒரு சகோதரி. அது இது ஒரு டெம்பரரி ஷெட் தான் நமக்கு சரீரம். ஆமா, இது ஒரு போர்வே சொல்லுது. கலைந்து போட்டு ஒரு நிகழ்ச்சியில் போகும். ஆமா, நிரந்தரம் யாருமே கிடையாது. ஆமா, யாரும் நிரந்தரமே கிடையாது. இந்த கொரோனா பிள்ளை எச்சரிக்கை பூத்தக பித்தனுக்கெல்லாம் பரலோகத்துக்கு எடுத்துக்கொள்ளப்பட்டிருக்காங்க. பிரியமானவர்கள், எத்தனையோ பிரியமானவர்கள் திருத்தங்களை கூட வசதி ஆண்டாக்குங்கிறது பெரிய ஒரு முடியாது. அதுவே மரணம் யாரையும் எந்த நேரத்தில் சந்திக்கிறான். ஆனா நான் நிச்சயத்துக்கு போகிறேன் என்ற நம்பிக்கையோடு மறிக்கத்தவன் ரட்சிக்கப்பட்டு நாடு ஏற்றுக்கொண்டு இன்று மறித்தவரும் நம்முடைய ராஜ்யத்துக்கு போகின்ற நம்பிக்கை நமக்கு அதான் முக்கியமான. எனக்கு 23 வயதாகிறது. நான் இன்றைக்கு மறுத்தாலும் ready to go to heaven to meet my Lord. அதான் முக்கியமான காரியம். அதுதான் முக்கியமான காரியம். உங்களுக்கு முக்கியமான காரியம். சிஸ்டர் ஒரு நாள் கூட முகம் வாழ்ந்த பார்த்து. ஆமா, எப்பவும் புரிசிரிப்பாவே இருப்பாங்க. சிஸ்டர் இளவரசி வீட்டுக்கெல்லாம் போயிருக்கு. அங்க ஒரு ஐயா ட்ரெஸ்ஸா இருக்கும்போது அடிக்கடி வருவேன் வீட்டுக்கு. ஏன்னா அடிக்கடி வருவேன். சிஸ்டர் ரொம்ப அதிகமாக கவனிப்பாங்க. வேலை பார்க்குறாரு சௌரி போட்டு உடனே காஃபி குடிக்கும்போது ரொம்ப அன்பாக நேசிக்கிறது சௌரி. அதனால அவர்கள் எல்லா தங்கள் பிரயாசங்களை விட்டு அந்த இலைப்பாதி கொண்டு 57:1 பார்க்கும் பொழுது நீதிமான் எடுத்துக்கொள்ளப்படுகிறான். தீங்கு நாள் வராதுக்கு முன்பே நீதிமான் எடுத்துக்கொள்ளப்படுகிறான். யாரும் அறிய மாட்டேங்கிறாங்க. ஒரு தீங்கு நாள் வரப்போகுது, பொருளாவோட மோசமான ஒரு காலம் வரப்போகுது. அதுக்குள்ளாக தேவன் தம்முடைய நீதிமான்களை ஆண்டு நினைச்சாரு, எடுத்துக்கொள்றாரு. அதான் உண்மை. ஆமா, நீதிமான்களை தேவன் எடுத்துக்கொள்கிறார். பெரிய பயங்கரமான காலம். இது பொல்லாத காலம் சொல்றோம், கடினமான காலம் சொல்றோம், அநீதியான உலகம் சொல்றோம். உலகம் முழுதும் பொல்லாதவர்கள் கிடைக்கிறது வேதம் சொல்லுது. ஆனாலும் பிரியமானவர்களே, பொல்லாத உலகத்தில் வாழ்கிற நம்மை ஆண்டோடைய வருகையிலே எடுத்துக்கொள்ளப்பட்டிருக்கிறோம். அதனால அழகாக வேதாகமத்திலே பரலோகத்தை பற்றி அழகாக சித்தரிக்கப்பட்டிருக்கிறது. வாசிக்கணும். வெளிப்படுத்தி 7ஆம் அதிகாரத்திலே வாசிக்கணும், 21ஆம் அதிகாரத்தை வாசிக்கணும், 22ஆம் அதிகாரத்தை வாசிக்கும் பொழுது சீக்கிரமா அந்த போயிடலாமே நினைப்போம். சீக்கிரமா இருக்கிறது ஏன் உலகத்துல எப்படி அப்படி ஜெபிக்க தோணும். ஜெபிக்கக்கூடாது. எளியா ஜெபித்தான் ஆண்டவரே போது ஆண்டு எல்லாத்துமா எடுத்துக்கிறது ஆண்டவர் எடுத்துச்சு. ஆமா, அவன் ஆண்டவர் நமக்கும் ஒரு காலத்தை வைக்கிறார். ஆண்டவர் ஒவ்வொன்றுக்கும் ஒரு காலம் இருக்குது. அவரு சகோதரி அவருடைய காலத்திலே அவர் நமக்கு பிரியமான மலர் வந்து இருந்துச்சு. ஒரு தோட்டக்காரன் போய் அவருக்கு பிரியமான மலரை பிடிக்க அவருக்கு திருமணத்துக்கு உரிமை உண்டு. அவருக்கு உரிமை உண்டு. ஏனாண்டவரே இந்த மலரை பறித்தான்னு கேட்கறதுக்கு வேலைக்காரனுக்கு கிடையாது, போனதுக்கு அதிகாரம் கிடையாது. தமக்கு பிரியமான மகனாக ஆண்டவர் எடுத்துக்கொண்டார். அதனால யோபு 1:21 இன்னைக்கு எங்களுக்கு ஒரு மீட்டிங், இது பிரேயர் மீட்டிங், பைபிள் சிஸ்டி. அதாவது தர்மராஜி பேசினாங்க. நான் நன்மை நகரம் போயிருந்தேன். அன்னைக்கு ஒரு துஷ்டி அப்ப அந்த போதகரு யோபு 1:21 வாசிங்கன்னு சொன்னாரு. அது வாசித்துட்டு விசுவாசி அந்த வாசித்தாரு. நிர்வாணியா என் தாயின் கற்பத்தில் வந்து நிர்வாணியாய் அவரிடத்தில் திரும்புவேன். கற்றல் எடுத்தார் சோத்திரம் என்று சொல்லி இந்த வசனத்தை வாசித்து எல்லாரும் அந்த குடும்பத்துக்காக நீ ஜெபிக்கணும். விசுவாசி எல்லாரும் அந்த குடும்பத்துக்காக ஜெபிக்க நான் இன்னைக்கு போயிருந்தேன். எனக்கு அப்படியே புள்ள வச்சு போச்சு அப்படின்னாரு. இன்னைக்கு அவருடைய ஷேரிங் அவரு ரிட்டையர் ஆகி ஒரு 11 வருஷம் ஆச்சு. அவருக்கு 76 வயது. அவரு முற்பதாக்களின் ஜெபங்களை கொடுத்து தியானம் பண்ணாங்க. அப்போ விசுவாசிகளுக்கு நானும் கூட இருந்தேன். ஏன்னா எதிர்பார்க்கவே இல்லை. எனக்கு புல் வச்சு போச்சுங்கிறாரு தர்மராஜ். இன்னைக்கு எங்க மீட்டிங் நடந்தது, பைபிள் சிஸ்டி மீட்டிங் நடந்தது. அவர் சொன்னது எனக்கே நான் கூட ஒரு நாள் சொன்னது அப்படின்னு சொன்னதாக அவர் வாழ்க்கை சரித்திரத்தை பேசும் பொழுது அப்பொழுது இந்த வசனத்தை